warm good evening to everyone who's logged in today from India, and a very good morning to everyone who's logged in from Cairo. I welcome you to this 12th International Symposium in Diabetes, and especially today's meeting, the joint AASD CMRE Symposium in Diabetes that we have been doing in collaboration with AASD, Arabic Association for Study of Diabetes, led by Professor Inas Shaltout from Egypt. And a very warm welcome to all our faculties who are logged in from the Arab countries, from Egypt, from Cairo. We have logins from UAE, from the Middle East, as well as from India. So I welcome all of you, Professor Inas. It's always a pleasure to have you with us. It's a great partnership that we enjoy. And welcome to India. And I'm sure tomorrow at the physical meeting also, we're going to have great interactions. I also welcome all the other faculties who've joined. Dr. Iman, Dr. Hisham, Dr. Amr, Dr. Gamila Nasser, Dr. Antonio Cerello, and Dr. Mohammad Hasnan, who will be joining us in a little while. So CMRE, Consortium for Medical Research and Education, is a joint venture hosted by Dr. Rajiv Chawla, as well as by me from Delhi. And the whole idea is propagation of medical education. With that kind of a context setting, let me hand over to Dr. Rajiv Chawla, who is going to introduce CMRE and today's program before we kickstart the meeting. And I'll also, after Dr. Chawla, I would like to invite Dr. Inas also to say a few words before we start. Dr. Rajiv Chawla, please.
Thank you, Dr. Shalini. Good afternoon, everyone. Dignitaries on dais, Professor Inas, Professor Mohammed.
Your video is off, sir. We can't see you.
Yeah. Am I okay now? Good to go? Okay.
Yes.
Good afternoon. Dignitaries on dais, Professor Inas, Professor Mohammed, Professor Hisham, Professor Amir, Professor Iman, Professor Gamila, and Professor Antonio to join subsequently. It's a great pleasure for me to welcome you all to the 12th International Symposium being hosted by CMRI in partnership with AASD, that is Arabic Association for Study of Diabetes. And we are fortunate enough to have most of the faculties from AASD, including Professor Inas Shaltout, Madam, who is with us and going to be with us tomorrow also for the physical meeting. Year after year, I think it is possibly the 5th or the 6th year, we have partnered with ASD. We are getting stronger and stronger. And this, over last few years, CMRE and ASD, this platform has become one of the very significant scientific platform, not only for a dialogue, a discussion, a discovery, but also for dissemination of knowledge in field of diabetology across the globe, I'll say, at least in the Middle East, UAE, some parts of Europe, and across India also. So the sole purpose, the mission of this giant partnership and the conference is to reach to a greater or widen our horizon and to reach to a greater, you may say, those who can benefit, delegates, those who can benefit from this international symposium in diabetes. And I'm sure year after year, it is getting very, very popular. And we are getting more and more scientific deliberation into that. Good thing is that we are able to exchange. We are, maybe many times there could be ethnic differences, but by and large, we share the same ethnicity and we share the same concerns and the issues which are there in your country and in India also, in terms of our knowledge, in terms of, you may say, challenges which are there when it comes to management of type 1 or type 2 diabetes in this part of the world, because we are also resource limited country like most of the Middle East countries. So it is a common challenge which we need to address together, and we see it as a way forward in reaching to greater, you may say, delegates registration. And I'm sure they are going to benefit from our discussion which are going to happen over the next 3.5 hours. So it is again a great pleasure, and we are very, very grateful to all ASD members and office bearers for making it year after year. So thanks a lot, and I'm sure all those delegates, those who have logged in and will keep subsequently joining, they are going to benefit from this scientific feast, which is going to be an excellent mix of basics as well as clinical science in diabetology. So with that, we'll request Professor Inas to address, and then we can start the scientific deliberations. Over to Professor Inas.
Thank you very much, Professor Rajiv. And it's my pleasure and honor to be here and to collaborate for the 12th ASD CMRE event. It's getting crowded with speakers and also with attendees. It's also my pleasure to cooperate as an Egyptian association with one of the important countries with old civilization like India. Together, Egypt and India are having maybe the most ancient civilization in the world. So this gives me proud, really. Today we will have speakers from ASD, Professor Amr al-Maliki. He's the former chair of the internal medicine department in Cairo University. Professor Gamila Nasr, she is the chair of the board of cardiology in Egypt. Professor Hisham Magdeddin, he's a professor of internal medicine and endocrinology in Cairo University. Professor Iman Sharif is working in Swiss Canal University. So we are having good representation of ASD, and also Professor Muhammad Hassanin. Professor Muhammad Hassanin is a key person in ASD, and he's going to join soon, and he's professor in Cardiff University and professor in Emirates. So let's start our lectures today, and hope to have you, dear professors and dear colleagues and attendees, for the coming 2 days in a successful event.
Thank you, Professor Inas, for very encouraging words of wisdom. And I'm sure that both the organizations are going to have a mutual symbiotic and a positive relationship in terms of dissemination of knowledge and skill to these parts of the world. So, with that, we may start the scientific proceedings. And may I invite the first speaker? She is going to be Professor Iman. Can I have her slide? Introduction slide. Yeah, Professor Iman El Sharif, has done doctorate degree in internal medicine, master's degree in internal medicine, and currently she has been serving since August 2015 till present. She is a consultant internal medicine, Egyptian Medical Syndicate. June 2015 till present time, she is lecturer in internal medicine, endocrinology, and diabetes medicine. June 23 till present, member of Board of Arabic Association for the Study of Diabetes and Metabolism, that is ASD. October 2019, since then she is a member of Arab Association for Study of Metabolism. Since June 2023, she is a member of Board of Egyptian Research Station also, and she is a widely traveled international faculty, has had number of publication in peer-reviewed journals, and she's a wonderful orator. And year after year, we have been getting her in this conference, and she has been contributing to a great extent in terms of dissemination of science and knowledge. And she's going to talk about the first topic is that adipocyte role in developing metabolic syndrome. It's a not only a basic science topic, but I'm sure as a consultant in internal medicine and endocrinologist, she is going to make it very, very crisp for all the listeners. So let's have Dr. Iman for next 20 minutes. This dais is yours.
Thank you so much, Professor Rajiv Chawla, for the kind introduction. And thanks, Professor Shalini, Professor Ines Shaltut, for all the kind board, joint board of the AASD and CMRE for inviting me to be part of this very distinguished scientific event. It isn't the first time, and I hope it won't be the last time. Though my topic seems a bit basic, but we have to understand a bit basic knowledge about obesity so that we can correlate to the clinical events that we face with our patients. Next, please. My talk will, though we have a very busy agenda with a lot of topics. Next, please. It seems a busy agenda, yet we have to go through right now. What about the structure of the adipose tissue next? Structure, yeah, we have to go to structure right immediately. It had been long known that adipose tissue, next please, next Nilam. The main building block of the adipose tissue had been long known as the adipocytes. Lately, it had been shown that these are not the only structure, but there is another elements dispersed in the stromal vascular fraction, and these both parts, the adipocytes building blocks and the other elements dispersed in the stroma vascular fractions, are responsible for the plasticity of the adipose tissue. All of these parts or elements play a different role into the obesity. The pre-adipocytes differentiate into mature adipocytes. It regulates the adipogenesis and the white adipose tissue expansion, which white adipose tissue, we will come through this in few seconds, is responsible for mostly of all the endocrine actions of adiposity. The immune cells, as the macrophages and monocytes, are those who are responsible for dispersing the interleukins and the inflammatory markers and cytokines which we face in the obesity, diabetes, and cardiovascular events, while the endothelial cells and pericytes provide the vasculature of the adipose tissue by forming new capillaries every now and then. And the last one, the adipose tissue-derived stem cells, the ADSCs, are capable of self-renewal, and they are multipotent. They can differentiate into adipogenic lineage endothelial cells, and from these adipose tissue derived stem cells go on into the vascular visceral cells, the exosomes, which are responsible of inflammation. Next, please, Neil. What about the adipocyte physiological action? Actually, the main building block, next please, Neela. The main building block is, it has been long known that the main building block is responsible of the storage, energy production and storage. And this is quite established and is well known because adipose tissue is a complex metabolic organ. It regulates energy production and storage through the insulin sensitivity activities. Also, it has a classical nutrient role through the triacylglycerols homeostasis. They either they lipogenesize them, they store them, or during starvation, during fasting, they release the free fatty acids by the lipolysis. A bit new secretory functions, the endocrine hormones and the other complement factors and exosomes had been known to be there as a function of the adipose tissue. Next, please, Neela. The adipose tissue, it's an active organ with secretes a number of adipokines. Those adipokines are bioactive peptides which can be regarded as cytokines, peptide hormones, and enzymes which act in different activities or mechanisms, either paracrine, endocrine remotely, or autocrine manner, to regulate the energy metabolism and the immune responses, as well as the cardiovascular hemostasis. Adipokines mainly do two important things. They modulate the adipogenesis, the adipocyte metabolism, and the immune cell filtration locally into the adipose tissue. And this immune cell infiltration stimulates the macrophage and immunophage we mentioned earlier as a structure of the stromal vascular part of the adipose tissue. They exert their biological effects via the endocrine activities to maintain systemic homeostasis and insulin system. Next, please, Leo. They also, these cells, while the adipose-derived stem cells we mentioned earlier, produce and secrete the extracellular vesicles, which are exosomes with different diameters from as small as 30 to 100 nanomillimeters from the cytoplasmic multivascular bodies to micros ones, with a bit maybe bigger, from 100 to 1000. Both types of such extracellular vesicles are similar to the original cells in composition, and they are bioactive molecules. They are transfer the bioactive molecules, and they mediate the intracellular and the interorgan crosstalks. A lot of evidence we will show later in a few seconds, are very important in the regulation of the metabolic inflammation that takes place in the adipose tissue and the energy metabolism and the insulin sensitivity. Next, please. What about the types? Next, please. Adipocytes had been known longer as just white and brown. Actually, there is a color palette of adipocytes. The yellow one is still under investigations, not that clear, but the pink ones are derived from the white adipose tissue, and it's related to pregnancy. With the pink color is attributed to the milk content, milk secretion during lactation. The beige color contains both lipocytes, the cells with the lipid content, while the brown part is the mitochondria. This means that this type of adipocytes is responsible of both of energy storage and heat production for thermoregulation, and is found in those exposed to chronically long chronic cold exposure. We are left with the white and brown phenotypes of the adipocytes, which are widely studied and understood. Next, please, Neela. This may explain the differences on a histological view. The adipocytes has a very large white droplet, and as the lipid droplet comes smaller, this means that there is no much role for the lipogenesis and energy expenditure role, and the mitochondrial part, which takes place more in the brown adipocytes, is taking over the tasks for thermoregulation. Next, please, Neila. White adipose tissue is the primary site for energy storage due to the single large lipid droplet. It's a nuclear one. It's very high sensitive to hormones. It takes insulin to take up and store nutrients in the form of triglycerides after food ingestion, and it can secrete amines, be sensitive to biogenic amines such as catecholamines, to supply energy in the form of free fatty acids during fasting, prolonged fasting. Next, please. The main depots of white adipose tissue are located in the subcutaneous adipose tissue, which constitutes about 80% of the total body fat in the abdominal and gluteofemoral regions. And this is very important to understand. That's why the pattern of the pear-shaped obesity is to understand the difference between the apple-shaped and the pear-shaped obesity, or the central obesity, which is responsible for most of the cardiometabolic disease and diabetes as well. The visceral adipose tissue, which constitutes from 5 to 20% of the total body fat, is around the internal organs, around the pericardium, the periadventitial regions, the perigonadal, mesenteric, and retroperitoneal, while some small adipose depots may be found intermuscular and epicardial, and they have specialized functions related to these musculoskeletal and cardiovascular system. Next, please. While the brown adipose tissue is multimolecular, has a number of lipid droplets, but a large number of uncoupled mitochondria through a chemical activation of the mitochondrial membrane and proteins and uncoupling of proteins. The catalyzing activities in the inner mitochondrial membrane causes it converts the chemical energy into heat. That's why brown adipose tissue is responsible for thermogenesis. Next, please. And it has been long known that brown adipose tissue is located mostly in the neonates to prevent them from hypothermia, resulted from the high body surface mass area in relation to mass body surface area in relation to mass ratio. But recent studies with positive PET scan based approaches found that PAT brown adipose tissue can be found in the adults in some parts in the supraclavicular and ventral, cervical, and thoracic regions in the adults. Apart from the brown adipose tissue is the base adipose tissue, which has maybe some morphological characteristics and thermogenic capabilities and capacities, just as the brown adipose tissue, but it is different in the original. It originates from different precursor cells. That's why the amount and activity of brown adipose tissue in adults is negatively correlated with the body mass index, the weight, the type 2 diabetes development, and cardiovascular events. This is a comparison. Next, please. This diagram is a bit comparison between the disturbed perfusion of white adipose tissue and the brown adipose tissue. We came across this, and this is the types and morphology of the white, brown, and beige. We had gone through this while this. Next, please. Next, yes, we had gone through this earlier while explaining the pattern what adipose tissues. Next, please, Neela. Now we are going to consider how it participates into the obesity, how adipose tissue participates in obesity. Obesity is a very complex, multifaceted chronic disease. That's why we have to convey this idea to our visitors who think that they may go on some diet and exercise. For somebody, may take some of a couple of drugs or one of the new molecules available in the market for getting their weight down, and then they stop it. They have rebound weight gain, and so from the start they have to understand that obesity is complex. It's a chronic disease, and it is characterized by an abnormal and excessive accumulation of adipose tissue that may occur due to different types of reasons. The genetic influence affect the fat stores, the metabolization of nutrients, of triacyl glycerols, and the neuroendocrine signals and secretion of leptins and other signals. The other socioeconomic that might be controllable, for example, the education, trying to improve the poor quality of food and to go more active and avoiding the unhealthy lifestyle and stress. While those who other environmental factors may be in some societies can be abandoned, such as abandoning the high fat and sucrose diet, abandoning sedentarism, some medications which increase weight, but some chronic illnesses, for example, would need long-standing use of corticosteroids, for example, may be not avoidable, while those who have some industrial exposure to endocrine disrupting chemicals and pollutants may find it a bit difficult to change their occupation. All these intermingling reasons may be causing obesity in those with genetic susceptibility. Next, please, Neela. The adipocytes pathophysiology is obesity. Adipose tissue features and distribution damage the mechanism are damaging mechanisms. Adipose tissue undergoes several changes in the composition, distribution, and function, and increases so the risk of developing diabetes, cardiovascular, and other metabolic disease. Unhealthy expansion of adipose tissue is mediated by the hyperplasia and hypertrophy of adipocytes, increasing the adipose tissue inflammation. That's why the inflammation driven by activation of pro-inflammatory adipokines and cytokines such as the interleukin-6 and TNF-alpha, tumor necrosis factor alpha, provided by the macrophages we mentioned earlier in the stromal vascular part of the adipose tissue. Next, please, Nila. This is how the adipose tissue in relation to cardiovascular and diabetes goes. The features: increased adiposity, increased inflammation, decreased adipose tissue normal function we mentioned earlier, and so increased insulin resistance rather than the good activity of insulin sensitivity normally to be exerted by the white adipose tissue. And as the adipose tissue distribution, the visceral fat increase while the subcutaneous fat decrease, and this results in the lipid storage increase in the liver, in the skeletal muscles, and decreased lipid storage availability. All these result in hypertrophic changes and hyperplastic changes of the adipose tissue, lipotoxicity, and lipoapoptosis. Apoptosis gains more immune cells to secrete the adipokines and cytokines, and thus increase the risk for diabetes and cardiovascular disease. Next, please, Nilia. This had been published in the Frontiers in Immunology 2021, talking about the adipose extracellular vesicles we had mentioned earlier as part of the secretions of the adipose tissue stem cells. They show the adipose tissue dense vascularization and innervation, the key metabolic issues, all three triumvirate. This tri-cycle of activities go through changes result in the activation of the extravascular vesicles. Next, please, Nila. The chronic stressed next. This one, thank you. Chronically stressed microenvironment in adipose tissue, the triacylglycerols, which are provided in plenty from the adipocytes, fill the cytoplasm. This become hypertrophic, they increase in size, and they become hyperplastic. The differentiated adipocytes have remarkable hypertrophic potential as they increase in size in hundreds of micro diameters. They increase the mechanical stress over the contacts, the neighboring cells. This pressure, the mechanical stress or pressure, increases the hypoxia because of the limited diffusion of oxygen into the adipocytes, and this chronic hypoxia results in adipose tissue inflammation. That's why larger adipocytes have been found to correlate with the increased pro-inflammatory adipokine profile and greater collagen deposition and fibrosis in the adipose depot. And as fibrosis goes on, more more inflammatory markers are released, tumor necrosis factor alpha, and the excess of toxic lipid species as the free fatty acids accumulates in different organs, and this is known as the lipotoxicity. This lipotoxicity and the inflammation all participate into cardiovascular events and development of diabetes. Next, please, Neelam. Here comes the metabolic role of the white adipose tissue, which changes from the normal 80% subcutaneous distribution to more into the visceral distribution that shouldn't be more than 5 to 20%. And there is an crossed content. The subcutaneous becomes a bit lower than the visceral one. The endocrine functions of the abnormal white adipose tissue: it secretes many peptides, hormones, and steroids, all of which play the hemostatic role. The chronic unresolved inflammation have various detrimental effects on the various organs via the paracrine, uchocrine, and endocrine activities we mentioned earlier, while the visceral metabolites, visceral adipose tissue metabolites are peptides and adipokines, as the chimerin, adiponectin, leptin, and steroidal hormones, and other fatty acids and ceramides, all are of inflammatory role. Next, please. This is an important review that had explored much about the adipose tissue dysfunction and the role of adipocyte-derived extracellular vesicles in obesity and metabolic syndrome. Next, please. And it had shed light upon the adipocyte-derived extracellular vesicles as diverse groups of nanoparticles shed by different types of tissues as intracellular messengers. They are pi-layered lipid membranes enclose cytoplasmic soluble elements. They have different sizes, very small ones, apoptotic bodies, very, very small, and microvesicles, which are 152, for example, 500 nanomillimeters, which are a bit the bigger ones. Next, please. In human patients living with obesity, the levels of these circulating extracellular vesicles are too elevated in comparison to the lean subjects, suggesting that the extracellular vesicles released by the increased amount of the adipose tissue from obese persons could substantially contribute to this phenomena. They are important in the intracellular communication and signaling. They have a potentiality to act as biomarker. They act as a cargo because they had been proven to be stable, and they can be transported and been shown in some fluids in the urine and the blood. Next, please. The adipose tissue extracellular vesicles have three specific proteins that exert their functions. The retinol binding protein 4, it's very rich in the obese people. It induces the production of TNF alpha and the interleukin 6 in the macrophages, and they are correlated with the insulin resistance. Next, please. While the Lipin A is another marker of the human adipocyte-derived extracellular vesicles in obesity. They are a biomarker of the adipocyte health because they are specific adipocyte proteins that coat the lipid droplets and play a central role in the regulation between lipolysis and lipogenesis, and is markedly increased in persons living with obesity. Next, please. While the free fatty acids binding protein 4, mimican, is a novel potential, had been revealed as a novel potential marker, including fatty acid binding protein 4 with a complex naming. It has been shown that both mimican and the transforming growth factor beta induced are both biomarkers for obesity comorbidities, especially the type 2 diabetes and the cardiovascular events. Next, please. Are all, and after all we have mentioned, can we claim that adipocytes are all harmful? Next, actually, no, because there are some metabolically active, metabolically healthy obese adipose tissue, and other are not healthy. Both have high fat mass, but some of them have low insulin sensitivity and high ectopic fat. They provide high inflammation, high triglycerides, and low adiponectin. All these attribute to the disease of type 2 diabetes cardiovascular events. Still, we don't know much about the yellow color of the adipocytes. It's still under research, while the high fat mass, which has low ectopic fat, normalizing of the white adipose tissue from the subcutaneous fat to the visceral fat, exerts no inflammation, has low triglycerides and high adiponectin. That's why some people have apparently increased fat mass with obesity, but they are healthy, not having those increased markers of inflammation. For the time being, next please. I have to conclude that white visceral adipose tissue is centric to obesity related cardiovascular disease and diabetes. It provides a steady state, low grade inflammatory micro environment that can be elaborated can be shown through the biomarkers that can be measured. Visceral adipose tissue dysfunctions through mechanical, metabolic, and vector pathways, and still more research is needed regarding these topics, especially in clinical sense. Thank you. So, next, please. Thank you so much for your attention and for inviting me to this prestigious event.
Thank you so much, ma'am. This was a very enlightening lecture, and I think the perfect start for this program. I'm sure everyone must have really cleared their concepts, because very lucid lecture you planned on the role of adipocytes in metabolic syndrome. I would request you to stay back for the discussion once we're done with the next sessions, please.
Okay, it will be my pleasure. Thank you.
Thank you so much, ma'am. So with that, we now move on to our next speaker, Dr. Hisham Magd-Eldin, who will be talking on the role of melatonin, metabolism, and the pancreatic clock. What is the link? To introduce Sir, he is Professor of Internal Medicine and Diabetes at Cairo Governorate. He's MD Internal Medicine, MSc Internal Medicine from Cairo University, along with MBBCH from Cairo University. He's consultant of internal medicine and diabetes in Al Muasa Al Ilajia from 2006 till now, professor of internal medicine and diabetes from 21 onwards, consultant endocrinology and public health insurance authority from 2007 onwards. He's also consultant of internal medicine and diabetes private clinic Manial Street at Cairo. He's been part of a lot of scientific events, has been part of the annual AASD meeting 2021 as chairperson and speaker. Also involved as Internal Medicine Department, Cairo University annual meeting as chairperson and speaker. He has been part of the virtual ESD annual meeting in 2020 as well as ESD Vienna 2015. He serves as an advisory board member for many pharmaceutical companies and has been speaker and chairperson in standalone events in different national and multinational companies. So Sir is going to talk on melatonin, metabolism, and the pancreatic clock, another very unique topic. Thank you so much. Welcome, Sir. Professor Hisham.
Thanks, Dr. Shalini. It's a great pleasure and honor to be part of this marvelous international meeting. And I will discuss one of the important hot topics these days, as we will see.
So your video is off. We can't see you.
Now it's clear now. The
Yes.
presentation now is on the screen.
The presentation is not yet on the screen, sir. We can see the list of presentations in your drive. Yes, now it is clear, sir.
Today I'll discuss one of the very recent importance. The points I will discuss, I will go through a rapid introduction and evolutionary history, then relationship between melatonin and the pancreatic islets, and if so, if there is any impact on diabetes and its complication, recommendations and indications. Actually, melatonin is a very ancient molecule that can be traced back to the origin of life. As we will see, melatonin initially assumed to be a free radical scavenger. It's presumably evolved in bacteria. After this related identification, identified in the cow and then in different tissues. We can see here more than 3 billion of years. It's assumed that melatonin was present in prokaryotes, but then it was developed into plant and animal kingdom. But coming back to present, which is in August 2020, and we can see this nice review article discussing melatonin rules and therapeutic potentials. And we can see here that melatonin secreted from the pineal gland, from the brain. It's not only important to synchronize sleep, but also it provides neuroprotection, myocardial damage, it promotes bone health, and lastly, but not leastly, it's increase concentrate on this point these days. Again, here we can see here in this month this nice review article discussing the therapeutic potential of melatonin and its novel synthetic analogs, not only in circadian rhythm sleep disorders, but also inflammation associated pathologies and neurodegenerative disease. Melatonin as a tryptophan-derived hormone, it's mostly derived from or produced from pineal gland, but it was also located in several tissues and organs. This production is rhythmically controlled by complex clock gene networks, mostly in the master pacemaker located in the suprachiasmatic nucleus and the hypothalamus. And melatonin is usually secreted during the dark phases, and it has many neuroendocrine physiological functions. Let's concentrate on the interrelationship between melatonin and pancreatic islets, and we can see that melatonin exerts its influence on two receptors, melatonin 1 and 2. Both isoforms are involved in the modulation of insulin and glucagon secretion from alpha cells, and it is postulated that desynchrony of this function may be a factor in developing type 2 diabetes and its complication. Here, this diagram to show the interrelationship between actual melatonin in the action on the beta cells. In addition to many other factors, it acts on the melatonin receptor 1 and 2 through G proteins and through a lot of clock gene expressions. It will control insulin secretion. This notion has recently been supported by the genome-wide association, which identifies the melatonin 2 receptor as a risk factor actually of diabetes. So there is clear relationship between melatonin action and development of diabetes. But since melatonin is secreted in a diurnal fashion, we can say also that it has an effect on diurnal impact on the blood glucose regulating function. And according to Palino, circadian rhythm abnormalities in this part has been linked to metabolic syndrome, which includes diabetes and obesity. Moreover, it was found that oral melatonin administration in rats can enhance beta cell function. On the other hand, it was GLOT1 and GLOT2 receptors was present in the pinealocytes and may have some effect on the melatonin receptor insufficiency. And it's assumed that a key factor in the beginning of type 2 diabetes may be reducing melatonin secretion as a result of nighttime light exposure, which all of us have facing this problem in our modern life. And numerous studies linked type 2 diabetes with reduced glucose tolerance with disturbed sleep pattern. Again, it was found that people with type 2 diabetes mellitus produce less melatonin at night. And again, some studies show that melatonin can increase insulin sensitivity, but we cannot ignore that the melatonin antioxidant properties are very effective and very important and antioxidant against oxidative stress, which plays important role in diabetes and its complication. And here to show the interrelationship between the pineal gland and the pinealocytes with the islet beta cells, where catecholamines play an important role in this interaction. Is there any impact of circadian disruption on glucose metabolism and in implication on type 2 diabetes? We discussed the physiological role of melatonin and its role in also in physiological properties and circadian rhythm. But we can see here that the circadian system, which is the biological clock, consists of two parts. One is the central clock. We have two parts, two clocks, two types of clocks in our body. The central clock, which is present in the suprachiasmatic nucleus of the hypothalamus, and the other one is the peripheral clock located in different tissues. And these clocks are synchronized by neuronal and hormonal and during through feeding and physical activities. And we cannot deny actually that disruption of circadian rhythm still at the moment are an overlooked risk factor for diabetes. Many studies have demonstrated significant association between circadian disruption and increased risk of type 2 diabetes. We can imagine that shift work from morning to night has been associated with a 10 to 40% increased risk of diabetes, a very significant percentage of increase actually. And here to show that this is the central clock in the suprachiasmatic nucleus where where light will be act on this clock. On the other hand, we have peripheral clocks in the liver, in the stomach, in the suprarenal glands, in the muscles, where feeding and exercise play the important role. Here to show that during alignment, where the light being awake, feeding, and physical activity in the morning, and here during misalignment, as it happening very frequently in these days, we are awake with exposed to light and feeding and physical activity at night. We can see here that this is a normal secretion of melatonin, and this is flattening or loss of secretion of melatonin in the dysregulation. And this to show that this misalignment can cause glucose intolerance, where after getting the test meal instead of the morning in the evening, we can have more glucose level, less insulin level because of these circadian abnormalities. Here again in Frontiers in February 2025, they are discussing a new player in this interaction between circadian rhythm and glucose metabolism, which is the glucokinase. And it's mentioned that both in the central clock and in the peripheral clock, we can see that glucokinase play an important role. What is the importance of this? They said that the circadian dysfunction was related or is related to a diabetic microvascular complication like neuropathy, retinopathy, and nephropathy, and again with microvascular complications and cardiomyocytes. And we can target these circadian rhythm abnormalities in the prevention and treatment of these complications. The treatment is two parts, non-pharmacological, which depends on environmental and lifestyle regimens like light therapy, time-restricted feeding, sleep intervention, or schedule or combination of this one. And again, the pharmacological may be through modulating the glucokinase, either activators or inhibitors. And it's promising that activating glucokinase is a promising strategy actually for reducing glucose level, but it can cause many side effects. So it's not of that practical importance at the moment. Other circadian rhythm related medication, we can see here melatonin has been demonstrated to entertain the circadian system and has been found to possess sleep promoting properties. Also, it improves glucose homeostasis as we discussed and reduce insulin resistance in addition to orexin. Here we can see in this diagram that to restore the circadian synchrony, we have non-pharmacological treatment like the time-restricted feeding and bright light therapy, and pharmacological treatment where melatonin is one of these. So melatonin plays an important role both in physiology and in pathology and pathophysiology of diabetes and its complication. And by targeting this molecule or this circadian rhythm abnormality, we can prevent or delay or treat these complications. Here again, in 2025, we can see that they are stressing sleep habits in the pathogenesis and management of the obesity. And they said that sleep is an essential component of everyday life, actually, and play an important role in regulating many physiological processes. And updated guidelines include now adequate sleep as one of the key elements in lifestyle therapy. And there are many research recently demonstrate a U-shaped relationship between sleep duration and not only glycemia, but also with cardiovascular events and mortality. Here to show that not only is sufficient sleep, but nowadays, again, extended sleep or sleep disorders like insomnia, sleep apnea, and circadian disruption can cause diabetes, and this diabetes can cause cardiovascular event and mortality. It was found that insufficient sleep decrease insulin sensitivity and increase low-grade inflammation. It affected the appetite regulation with increase in weight gain and hyperglycemia diabetes. Here in the circulation, this year again, they stressing very, clearly the sleep irregularity, circadian rhythm, and the cardiometabolic disease risk, and give a red alarm actually that sleep irregularity now has becoming increasingly prevalent as a part of our modern life these days. And many studies found highlighted the role of sleep irregularity in obesity, metabolic syndrome, diabetes, cardiovascular disease, and mortality. And we can see that there are many postulated actually pathways or mediators for this link. Short and long sleep durations were associated with an increased risk of mortality, with long sleepers having a higher mortality risk of cardiovascular disease than the short sleepers, strangely enough. And the mechanism linking long sleep duration with poor glycemic control actually remain obscure, but it has been postulated that abnormally extended sleep is an indicator of poorer health and is associated with depression and low socioeconomic state rather than a direct causal relationship. So after discussing this promising and this very good news regarding the melatonin and the physiology and pathophysiology, and we can use it to prevent or delay or treat some of the complications of diabetes, what is the practical position of melatonin these days? We can see this review article in the Stat last year. And it stated that the best known purpose of melatonin actually is its role in promoting sleep. And until this moment, it's not officially approved for any indication by FDA. But it is stated clearly that exogenally supplied melatonin mimics the regulatory function of the endogenous melatonin. So it's helpful molecule, it's safe molecule. It could be a supplement rather than a drug. Moreover, melatonin receptor agonists, some of them are available on the market and are FDA approved for the treatment of insomnia. On the other hand, the American Academy of Family Physicians recognized melatonin as the first-line pharmacological therapy for insomnia, first line. And also it can be used for the management of post-traumatic brain energy, jet lag, neurodegenerative disorders, and migraine prophylaxis. It's used as off-label use in insomnia because it is safe, but the most important problem facing the practical use of melatonin actually is the variability in the studies, the variability in the doses used in the study and the outcomes and the overall study quality. But on the research base, there is, great potential role for melatonin in treatment of various conditions, including cancer, pain syndromes, cardiovascular disorders, GI disorders, and many other disorders. And this is because it has many biological mechanisms. As we said, it has an anti-cancer effect through activating tumor suppressor genes such as p53, bone deposition, again, important in metabolic disorders, as we discussed, cardiovascular disease, GI conditions, not only this, neurodegenerative disorders, mental disorders, pain syndrome, and even reproductive functions. Because melatonin is considered a supplement, the FDA does not regulate the supplements as vigorously as the pharmaceutical drugs because they are considered safe. And we can imagine that one study which examined 31 melatonin supplements discovered that the actual melatonin content varied widely, ranging from less than 83% to more than 478% of the label content. So there is great concern about the accurate doses in these studies. It could be administered through oral tablets, oral liquid, or rectal suppositories or transdermal. We have immediate release, extended release, and both combined immediate and extended release. The dose is not well defined. There is no maximum dose. In the study, the dose ranges from 0.1 milligram to 10 milligrams. Of course, we should exercise caution in patients with hepatic impairment, but it's clearly stated that melatonin does not induce hepatotoxicity. Again, in renal impairment, we should exercise some caution. Females during pregnancy and breastfeeding should avoid its use. Specific patient population also in pediatric patients. Surprisingly enough, melatonin production usually starts around the month of 3 months of age. Our infants at the age of 3 months they produce melatonin. But of course, supplementing infants with melatonin could raise some problems, some concern about the side effects. Older patients also, although it's considered generally safe, but there is some reports potential risk of falls and fractures. Melatonin is relatively a non-toxic molecule, although there is some mild adverse effects which have been reported with higher doses and extended release formulation, like drowsiness, daytime sedation, nausea, headache, but no evidence of just tolerance because it's metabolized by the enzyme CYP1A2. So caution should be used when using drugs using the same enzyme. And again, of course, it should not be used with other sedatives or hypnotics. The melatonin demonstrates actually remarkably low acute toxicity. But at supraphysiological doses, it may result in minor adverse drug reactions like gastritis, headache, insomnia, but not cause fatalities. But a recent analysis raised concern indicating significant increase actually in annual pediatric melatonin overdose from 2012 to 2021. What is the actual recommendations in American Diabetes Association 2025? Again, they stressed clearly that sleep occupies approximately 1/3 of the day of most people and modulates a lot of metabolic, endocrine, cardiovascular process. The latest AASD consensus highlights sleep as a central component in the management of prediabetes and diabetes. And again, there is U-shaped association between sleep duration and type 2 diabetes between 6 and 8 hours. Not only the duration, but again, poor sleep quality was associated with 40 to 84% increased risk of developing type 2 diabetes in the meta-analysis. Very significant, actually, relationship between poor sleep quality, which most of us actually are complaining of this problem these days. And for those going to bed late and getting up late, there was a 2.5-fold higher odds for ratio for type 2 diabetes than those going early. So what I want to stress actually that because diabetes is prevalence is going up, we need to explore more and more efficient therapies for its treatment and treatment prevention of complication. And we can see that melatonin, one of these molecules, which can modulate various signaling pathways and physiological processes, but still, of course, we need to have more and more human clinical trials with better standardization. But we cannot deny at the moment that the most important point while we are treating our patients in our clinic, please concentrate on sleep as a central component in the management of prediabetes and diabetes, and melatonin may be of help in this point. And thank you very much.
Thanks a lot for a very, very wonderful oration on a very, very difficult topic, melatonin, metabolism, and the pancreatic clock. And I'll request you to please stay back till the end of this session so that we can have some discussion after the third session. With
Okay,
that, we go to the third session that is about common endocrine disorders causing secondary diabetes. And for this, we have Professor Amar Al-Meghiri. He is an emeritus professor of medicine, diabetes, and endocrine faculty of medicine, Cairo. He is former head of the Department of Internal Medicine, Faculty of Medicine at Cairo University. He is a former head of Diabetes Endocrinology, Clinical Nutrition, and Metabolism Division, and is a director of Diabetes and Endocrinology Clinic, Faculty of Medicine, Cairo University. Currently, he is serving as Vice President of AASD and has huge number of publication, a wonderful orator and a excellent speaker. So over to you, Dr. Ahmed. You are muted.
Thank you, Professor Raji, for this introduction. And I wish to express my thanks to you and to Professor Shalini for inviting me to participate in this conference. Thank you very much. I have sent the presentation to
Neelam, are you running the slides?
Pardon, sir, we have not received your slides, sir.
Okay, Dr. Amar, you may continue from your side.
Okay.
Yeah, share your slides from your desktop or laptop.
डाल दे एक दो.
It appeared?
Yeah. You may put it in slideshow mode.
Okay. Okay.
Yes. Yeah. We can see it. It is in slide mode session. Yeah. Please continue.
Sir, sorry to interrupt you, but there is no sound. You have to just choose share with sound.
Sound? Okay, I will mute it and I will present.
Sir, you have to soft share and share again.
I will
This
share,
time,
yes, I will share
yeah.
and I will speak by myself.
Okay.
Okay. It's okay.
Yeah, it's okay.
You see the presentation?
Yeah, we can see and we can hear you. Yeah.
Sound is heard?
No, sir, there's no audio. Can't hear you.
Okay, I will speak by myself. Secondary diabetes is defined as a diabetes that results from an underlying condition or medication that disrupts insulin secretion or action. Secondary diabetes accounts for 1 to 2% of all causes of diabetes. Most important causes are endocrinopathies, disease of the endocrine pancreas, post-transplant diabetes, drugs and chemical-induced, also infections. Sorry. Endocrinopathy associated with secondary diabetes or abnormal glucose tolerance. Cushing syndrome, diabetes occur in 40% of patients and pre-diabetes in 20% of patients. In acromegaly, diabetes occurs in 30% of patients and pre-diabetes in 65% of patients. In hyperthyroidism, diabetes occurs in 2% and pre-diabetes in 50%. Pheochromocytoma 2 to 5%, and pre-diabetes occurs in 12 to 75%. In primary aldosteronism, diabetes occurs in 22%, and pre-diabetes in 28%. Glucagonoma and somatostatinoma 60 to 90% have diabetes. What are the risk factors for developing secondary diabetes in patients with endocrinopathies? The higher the hormone or hormonal product levels, the longer the duration of the disease, the higher age, the higher BMI, also positive family history, and pre-diabetes and previous GDM are at risk of developing secondary diabetes. What is the importance of identifying patients with secondary diabetes? Secondary diabetes increases the overall cardiovascular disease, perioperative mortality, morbidity. Unlike type 1 or type 2, diabetes remission may occur after successful treatment in most cases. So screening for diabetes is essential in these diseases. This slide shows a case with Cushing syndrome, a patient with acromegaly, also necrotizing migratory uremia in a patient with glucagonoma. Usually, the picture of the original condition dominates the clinical picture and is apparent. However, in few cases, the original condition may not be apparent, as in patients with resistant diabetes or hypertension. Screening for Cushing syndrome may be positive. The mechanism for developing hyperglycemia in endocrine disorders is complex and multifactorial, include insulin resistance, impaired insulin secretion, beta cell dysfunction, and increased lipolysis and excess glucagon secretion. All the endocrine conditions as acromegaly, Cushing syndrome, thyrotoxicosis, in these conditions, these hormones are anti-insulin hormones, so they result in increasing insulin resistance. This will result in disrupted insulin signaling cascade and decreased uptake of glucose by the muscle and adipose tissue. Also decrease hepatic glucose production due to inhibition of gluconeogenesis and glycogenolysis. Also, these hormones induce lipolysis. This will result in increased free fatty acid release, leptin release, beta-factin, adipocytokines as interleukin-6, tumor necrosis factor, also decrease adiponectin and inflammatory cytokines. All these factors result in increasing insulin resistance. Regarding the pancreas, these hormones result in inhibition of insulin secretion by the beta cell, also induce glucagon secretion by the beta cell. Beta cell dysfunction also occurs due to the effect of these hormones or other factors, inflammatory cytokines, oxidative stress, inflammatory markers, and more liable to occur in patients with prolonged conditions. There are specific mechanisms for hyperglycemia in some conditions. In Cushing syndrome, there's increased neuropeptide Y and increased appetite and visceral fat. In hyperthyroidism, the rapid gut glucose absorption, insulin degradation, also increased biologically inactive insulin precursors. Somatostatinoma, decreased insulin secretion, decrease in creatine effects. All these factors are present in somatostatinoma. In aldosteronism, hypokalemia has a basic role in inhibiting the beta cell function and diabetes in patients with aldosteronism. Aldosterone directly inhibits has inhibitory effect on insulin secretion by beta cell, also inflammatory mediators and reactive oxygen species induce beta cell damage. Management of hyperglycemia in patients with endocrinopathies. Treatment is directed to the primary condition and management of hyperglycemia, which includes lifestyle and anti-diabetic agents. Actually, normalization of the hormone level is supposed to alleviate the hyperglycemia. In most cases, however, diabetes persists in a significant number of patients even after successful treatment due to persistent beta cell dysfunction and metabolic imprinting due to the chronic increase of the anti-insulin hormone. Here is a condition like the metabolic memory in patients with type 2 diabetes. This slide shows remission rate in patients after successful surgical treatment of some conditions in Cushing's syndrome. At 1 year, 34% have persistent diabetes. In acromegaly, 25% had diabetes. In pheochromocytoma, 10% had diabetes after successful surgical treatment. Predictors of diabetes persistent after successful surgical treatment are the same as the risk factors, the hormone or hormonal product levels, duration of the disease, age, BMI, family history, presence of pre-diabetes or pre-diabetes, or previous gestational diabetes. This study was published in 1990, shows hypoglycemia. Severe hypoglycemia occurs in 6 out of 45, that is to say, in 13% of patients with pheochromocytoma 2 to 4 hours after adrenalectomy. This occurs due to the sudden drop of excess epinephrine result in enhanced insulin secretion in beta cell. This is alpha 2 receptor alpha 2 receptor and inhibition of glucagon secretion by alpha cell, which works on beta receptor. Somatostatin receptor agonist, pasireotide, has high diabetogenic potential compared to first generation somatostatin receptor agonist. Pasireotide has high affinity 40 times to receptor 5 than peptidotide, which are present in beta cell, resulting in severe inhibition of insulin secretion and more risk of hyperglycemia, in addition to decreased GLP-1 and GIP. Management of hyperglycemia in patients with endocrinopathies include lifestyle management, weight management, insulin in severe hyperglycemia or hyperglycemic emergencies. In glucocorticoid excess states, postprandial glucose is especially elevated, so basal bolus regimen is higher prandial. Basal insulin ratio is required. Main treatment in pheochromocytoma, glucocorticoid, somatostatinoma is insulin. Metformin is the first line of treatment because of the central role of insulin resistance in developing hyperglycemia in most of these conditions. Metformin results in inhibits hepatic gluconeogenesis and decrease hepatic glucose production. It's weight neutral or induces slight weight reduction. GLP-1 receptor agonists are used if metformin is not enough. GLP-1 receptor agonists have high to very high glucose lowering potency with low hyperglycemia risk, weight reduction, and the cardiorenal protective benefits. Also have a strong role in obese and high cardiovascular risk patients, so they are preferred in Cushing's syndrome and acromegaly, where weight and cardiovascular risk are major issues. It's not effective in glucagonoma due to the excessive catabolic state, and in somatostatinoma with severe insulin deficiency, who has limited role in pheochromocytoma. Insulin is recommended in these conditions until surgery. Regarding DPP-4 inhibitors, have low hypoglycemia risk and weight neutral. However, the modest glucose lowering effect in face of the very high insulin resistance makes them unsuitable as monotherapy can be combined with metformin or other drugs. Regarding sodium glucose transporter 2 inhibitors, blood glucose reduction, many benefits as weight reduction, blood glucose reduction, and cardiac protection, blood pressure improvement. They are excellent options for patients with hypertension, cardiovascular disease, CKD. These conditions are common in acromegaly, aldosteronism, and Cushing. Less effective in tumor causing insulin deficiency, so they have limited role in phagocytoma, ineffective as monotherapy in glucagonoma, ineffective in somatostatinoma. That again, insulin is the main treatment in these conditions. Also, there is a concern about increased risk of genital infection in Cushing syndrome and fluid depletion in phagocytoma. These are insulin sensitizers, have a slow onset of action. They work after 6 weeks. They have many unwanted effects and some concerns as fluid retention, which are not desirable in Cushing syndrome, acromegaly, and phagocytoma. Also, weight gain is not desired in syndrome and acromegaly. Bone fracture, these patients with hyperthyroidism and Cushing are at a risk of increased fracture, so this not preferred in these patients. Also, there is a concern about increased orbital fat deposition, so not recommended or not can aggravate Graves' orbitopathy and not referred in Graves' disease. Regarding the sulfonylurea, they estimate insulin secretion from the beta cell used in mild hyperglycemia due to endocrinopathies with impaired insulin secretion, as in aldosteronism-related hypokalemia and mild phagocytoma, often in infective endocrinopathies with severe insulin deficiency, as in glucagonoma, phagocytoma, and somatostatinoma, not preferred in Cushing and acromegaly due to weight gain potential, however, used in mild and moderate hyperglycemia with metformin or as a monotherapy if metformin is contraindicated or not tolerated. Have high hypoglycemia risk, especially after cure of primary endocrinal disorder. Patirootide-induced diabetes mellitus GLP-1 receptor agonist sodium glucose transporter 2 inhibitors are the preferred anti-diabetic agents in refractory hyperglycemia in Cushing, in addition to insulin metyrapone, which inhibits adrenal steroid synthesis, or mifepristone, which is glucocorticoid receptor blocker, are used in the pre-operative period for rapid control of blood glucose in pre-operative period. Take-home message: screening of patients with endocrinal disorder for diabetes is important, as hyperglycemia increases overall and cardiovascular morbidity and mortality. Hyperglycemia may persist in a significant proportion of patients with endocrinopathies even after successful treatment of the primary disorder. In addition to metformin, GLP-1 receptor agonist, sodium glucose transporter 2 inhibitors are preferred medications in the management of hyperglycemia, especially Cushing syndrome, acromegaly, and aldosteronism. And thank you.
Thank you, Dr. Amar, for an excellent oration on a very, very difficult and tough endocrine topic. So I'll request you to stay back and we can have some panel discussion amongst all the three speakers. So may I request to switch on your videos, Dr. Aman, Dr. Hisham, and Dr. Amar? Madam, you are there now. Dr. Iman is there. Okay, we may start with you. Your was the first topic, and today we understand that adipocytes are something like an endocrine organs. But how do adipocytes, they contribute beyond fat storage? We understand that the higher fat deposition, more so in the visceral adipocyte as compared to the subcutaneous, which induces inflammation. Do you think that is the only mechanism, or adipocytes, they contribute directly to overall metabolic syndrome or cardiovascular risks in some other ways also?
Your question, if I haven't understood the question right, and from the readings I gone through while preparing for the lecture, apparently there is some sort of a direct action and relationship of the adipocytes rather than just the inflammatory markers and the cytokines. This may be yet to be revealed via research. Still, genetic genome role not well known all over, and many research claim that all those who take the new medications as the GLP-1 receptor agonists or the GLP-1 combination, fixed ratio combinations, injections, when they stop treatment, they have rebound weight increase. There is a role for genetics that is yet to be revealed. And I think there is a role for the claimed yellow-colored adipose tissue in the palate yet to be revealed. Thank
True.
you.
Very true. There is
Dr.
another.
Iman, Professor Iman, if I can ask you, now that we know about the clear-cut role of adipocyte dysfunction, do you think and how can early identification of this adipocyte dysfunction alter the trajectory, especially of obesity-related diabetes per se?
I think from the late mini review published in 2024, I referred to in my lecture, we can go for measuring the extravesicular extracellular vesicles. These are biovectors cargo that can be measured through blood or urine. I think they are early to be released. I think we can some sort expect the dysfunction of white adipose tissue, visceral adipose tissue through these vesicles, but I have to go through the literature to know how can we measure them in the laboratory. Is it only a research base, or we can go to use it in clinical base through normal clinical pathology laboratories?
Yes, because as far as our country is concerned, these are only, kind of research level biomarkers that we do.
Yeah.
So similarly, despite knowing that adipokines have a huge role to play in the pathophysiology of cardiometabolic disorders, targeting these adipokines probably in the future could emerge as a good therapeutic strategy for preventing metabolic syndrome. Your thoughts on this?
Yes, I had gone through. I had presented a lecture. I think in the 19th AASD International Conference in Cairo. Thankfully, Professor Inaz gave me the chance to go through the therapies directed towards the inflammatory process underlying diabetes and cardiovascular disease. I think there is maybe a role in the future, but for the time being, all anti-inflammatory therapies have limited evidence, or they just act on one glycemic parameter rather than the others. Maybe some of the drugs by themselves increase the glycemic parameters. I think we have to come to do a lot of research and to try to bring those measurements, for example, the interleukin-6 and the TNF-alpha, to be regularly measured for the patients earlierly presenting with prediabetes, for example, to guard against developing cardiovascular events and progression into full-blown picture of type 2 diabetes.
Very true. Do we have any experience on hydroxychloroquine? That drug is available in India. Actually, it is a drug which has been sort of described and India is innovator in that, Indian company, and they have produced a lot of evidence on role of hydroxychloroquine in management of diabetes and metabolic syndrome. And even we have used in certain patients, and we found that there was an HbA1c reduction close to 0.5 or 0.6, and all the markers of inflammation go down. Is it
Okay,
available
that's
in your country?
up to my knowledge, this is hadn't been used in my country. Maybe my professors, Professor Hisham, Professor Amran, Professor Ines, maybe having a better experience or know a much better answer for that question.
Okay. The next question is for Dr.
Thank you.
Hisham. What role melatonin plays while we say it is a circadian rhythm regulator? When it comes to pancreatic beta cell, how does melatonin regulate circadian rhythm inside the beta cells, and whether it is through MT1, MT2, you describe it in what importance it has in clinical practice.
Thanks for the question. This is the main point in the presentation. It's not a straightforward actual statement. I cannot say a straightforward because, as you know, these subjects are have يعني, sometimes they have a positive effect, sometimes they have negative effect. But it's clear that the melatonin through action on melatonin 1 and 2 receptors, which are present in both alpha and beta cells of the pancreatic islets, can modulate the secretion of insulin and glucagon. And it's mentioned that because of the modern life, we are exposed to artificial light at night. As I showed in the presentation, this dysregulation of the circadian rhythm causing flattening of melatonin, and it may be a factor in developing diabetes, not only the incidence of diabetes itself, but also the incidence of its complications. The direct relationship between insulin, glucagon, and melatonin is still needs more and more research work.
And you think that there are certain genetic variations also in MT1, MT2 receptor, which could relate it to a higher cardiovascular or risk for developing type 2
melatonin
diabetes?
2, yes, melatonin 2 is a clear risk factor for developing type 2 diabetes at the moment.
And there are certain identifiable genetic variants or variations in those receptors, which could
Yeah,
be sort of screening for.
actually, yeah, all right. For the last 2 or 3 years, there are a lot of actually of researches discussing the genetic background and the isoforms of melatonin receptors and its relationship to the incidence of diabetes. It may be used in the future for the in the artificial intelligence for the suspicion of developing type 2 diabetes, predisposition to development of type 2 diabetes, either in type 2 and type 1. At the moment, practically, it's not yet clearly stated, but it's very promising, actually, very promising subject.
And there is another
Professor,
question by Dr. Girish Khurana that melatonin should not be combined with sedative, but do we have a lot of combination? In fact, we do have a lot of combination in India where they are providing melatonin with certain tranquilizers and sedative. You think that there is a reason to use them other than sort of inducing sleep or correction of circadian rhythm? Can it be used for reduction of cardiovascular or maybe metabolic risk or development of type 2 diabetes risk?
At the moment, as evidence-based medicine, we cannot recommend using melatonin for the prevention or treatment of cardiovascular problems of diabetes. But as we said, that sleep irregularity now is identified as a very important risk factor for developing diabetes and complication. And as I mentioned in the American Diabetes Association, now they are concentrating on putting sleep discussing with your patient about his sleep problems. Is it easy to go to sleep or difficult sleep quality? And treating these sleep problems can help in prevention of complications. Melatonin can be used in this area clearly, safely. Yeah.
But
Because
sir,
of the,
your take on whether we should be combining melatonin, because we have combinations available as with sleeping pills,
This
SSRIs
what's
and melatonin.
yeah. For those who are, exposed to high attitudes or there's problems of being sedated in the morning, it's better to be avoided to use melatonin because it helps to sleep with the sedatives or hypnotics. So it will increase the daytime drowsiness or sleepiness, which may be harmful in some subjects.
we
For
have been
others,
using,
no. For
yeah,
house, wife or like this, they can use it. But for some subjects, it will be, a little bit dangerous.
So do you think somebody presenting with insomnia or disturbed sleep as a patients with type 2 diabetes, obesity coming to you with insomnia, disturbed sleep, you should first try a melatonin, and if
Yeah.
that is not
I
helping,
mean,
then go on
uh,
to the other sedatives?
I mean, it's not at the moment FDA approved, but
Okay.
it's they said it's very commonly used in the Western countries, States or Europe, as an off-label use. But for the American Academy for Physicians, they're putting it at the first priority or the first, I mean, indication for it is the treatment of insomnia because I mean, it's a risk factor for developing many complications of diabetes.
Thank you.
Yeah,
Another
thank you.
very good question for Dr. Amir. Given the heterogeneity of secondary diabetes, what role could multiomics like genomics, metabolomics, and proteomics play in identifying unique metabolic signatures that differentiate endocrinal diabetes from type 1 and type 2 phenotypes?
For
Yes,
Dr. Amr.
yes. Regarding type 2 diabetes, usually it's type 2 diabetes when occur in patients with endocrinopathies. These patients may have already pre-diabetes or have high risk for developing diabetes, and so they develop diabetes. Regarding what are markers that can use to differentiate, I think I can't differentiate except after the response and the cure of the condition. If the condition is cured, it is 100% due to the endocrinopathy. If not, it is a patient with pre-diabetes or undiagnosed mild diabetes and exacerbated by endocrine disorder.
Thank you, Professor Amr. Another question for you. In patients with obesity and poorly controlled type 2 diabetes, do you suggest any biomarker panel, besides HbA1c, fasting glucose, etc., that can actually help us discriminate or differentiate between type 1, type 2 diabetes versus the endocrinopathies, secondary diabetes? Any biomarker panel?
Type 1 from type 2 from endocrinopathy?
Yes, differentiating endocrinopathy from the conventional diabetes that we talk about.
Type 1, I think, is differentiated by presence
Yes.
of C-peptide level
Antibodies.
and antibodies, yes.
Yes,
Type 2 is difficult to control. Actually, patients are obese, pre-diabetic, have risk factors, can't differentiate.
absolutely. So thank you so much, professors. It's been a great symposium and very interesting topics. We've had a very engaging audience, and thank you so much for answering all the queries that we've received. Professor Hesham, Professor Amr, Professor Iman, thank you so much for sparing time and being with us. With
Thank
this,
you very
we
much.
move on to the second symposium of this meeting. Dr. Chawla, please take over.
Yeah, with that, we go to the second session that is by Dr. Gamila, Cardiometabolic Chaos Decoding the Heart Diabetes Axis in 2025. Another very new topic, very novel topic, and I am sure we are all going to benefit from it. Dr. Gamila,
Can
can I
we have her
introduction?
CV, please?
CV slide? Yeah. She's professor and head department of cardiology at Suez Canal University and Ismailia Medical Universal Insurance Complex. She's head of the Scientific Council of Egyptian Board of Cardiology, diploma of echocardiography, and she's also a representative of International Society of Cardiovascular Disease Prevention and a board member of Egyptian Society of Cardiology. And she's a wonderful orator. We have had last 2 3 years also every time one presentation for her, and I'm sure she's going to do more than justice to this new topic that is cardiometabolic chaos decoding the heart diabetes axis in 2025. Over to you, Professor Gamila.
Dear all, I have the honor to participate in this honorable meeting between the Arabic Association for the Study of Diabetes and Metabolism and the CMRE India Thanks a lot, Professor Ines Shaltut, for the kind invitation. And I do have the real honor to participate in this very interesting presentation about chaos of diabetes, the link of diabetes and heart, which is really a very amazing interplay. So I'm just, this is my presentation. This is Gamila Nasr. And if I'm going to say, what about the cardiometabolic risk? Of course, if I can say Egypt in few words. Now we're witnessing a current age demographics and the population pyramid, as we are now seeing a lot of population who are having more aged population. So this is a real very good item. So should consider in a patient with diabetes, a patient with cardiometabolic risk. And of course, again, the life expectancy among Egyptians and males and females is very good, and it's rising in the last few years. This is an local study published in the Clinical Diabetes, and looking for the screening for diabetes and cardiovascular risk among the Egyptian population, and we found that according to the criteria for metabolic syndrome, around 20% of the Egyptians having metabolic syndrome. And this, of course, as we all know, that is a combination of several risk factors. And it's really in urban areas, it's a little bit high in Greater Cairo and Delta, it was a little bit. So this is the way we are talking about the Egyptian population. And my presentation about the cardiometabolic chaos, decoding heart diabetes access in the year 2025. Cardiometabolic chaos is a powerful phrase. Really, it's I feel very amazingly to share this very nice phrase, which is really very powerful, and it's describe a complex and intertwined and often unpredictable relationship between diabetes and heart. And so we're talking about cardiometabolic chaos, decoding the heart disease axis. What's diabetes? We all know that diabetes is a chronic condition that's characterized by raised by hyperglycemia. But actually, this is a new definition for the cardiologist, and say that type 2 diabetes is a condition of premature cardiovascular complications in the setting of chronic hyperglycemia. Of course, the impact of diabetes on cardiovascular disease mortality is well known, and we know that the diabetics are much more prone to develop cardiovascular disease, and the cardiovascular disease is responsible for 80% of mortality in diabetic patients. Again, if you look for the risk reduction with 1% only in the annual mean of glycated hemoglobin, this will be reflected upon the complications, microvascular disease, peripheral vascular disease, myocardial infarction, stroke, even heart failure, and cataract extraction. Again, in the UK prospective diabetes study, it was found that for glycated hemoglobin 1C, there is which says there is that's occurred in 2.3 heart failure events per 100 year. But if it is less than 6%, so if it is controlled, the occurrence of heart failure events is not that high. But for those who are uncontrolled, having glycosylated hemoglobin more than 10%, there occurred 11.9, approaching 12 heart failure events per 100 person per year. Again, this is really very alarming. And the epidemiology, we know that the 2/3 of patients with established cardiovascular disease have impaired glucose hemostasis, and it affects 30% of heart failure patients. And it's really, on the other hand, it's really very important to know that every 1% increase in glycosylated hemoglobin leads to an 8% increase in heart failure, and prevalence of heart failure in general population is 1.4 if you can compare it with the heart failure patient. What is the potential relationship between glucose and atherosclerosis? Definitely, there is a very intimate relation between the diabetes, and we can say that that there is a dual burden, and we see that a diabetes accelerates atherosclerosis, microvascular dysfunction, and inflammation. And heart with disease worsens insulin resistance, metabolic dysregulation, and glycemic control. So glucose has a direct endothelial harm, increase the oxidative stress, activation of polypol pathway, and basement membrane changes. All these lead to atherosclerosis. This is very interesting, and this is the cardiovascular disease in diabetes. It affects the coronary artery, vessels, endothelial dysfunction, increased arterial stiffness, calcium calcification, accelerated atherosclerosis, autonomic reduced heart rate variability, increased resting heart rate, arrhythmias, impaired glucose vasomotor capacity, and also affecting the cardiac muscle, and this with an impact of having diabetic cardiomyopathy, affecting the diastolic dysfunction first, and then comes the impaired relaxation, the increased stiffness, and leading to the systolic dysfunction. So it's a real vicious cycle, and there is the hyperglycemia leads to endothelial dysfunction, to coronary peripheral vascular disease, and so on. So diabetic cardiomyopathy, on the other hand, is a distinct entity characterized by the presence of abnormal myocardial performance or structure in the absence of epicardial coronary artery disease, hypertension, or significant valvular disease. So this was the original description that it occurred for diabetic patients with heart failure, but no evidence of coronary artery disease. Definitely, that diabetic cardiomyopathy is a cardiac dysfunction which affects approximately 15% of diabetic patients, leading to overt heart failure and death. So how diabetes looks to this? Because hyperglycemia causes significant functional alteration to cellular sodium-calcium ionic channels, and decreased extrapolation and increased intracellular concentration of ionic calcium, leading to dysfunctional cellular sodium-potassium channel with an increase in intracellular sodium. So this is really very important. And as we can see, this what happens really in the heart, looking as diabetic cardiomyopathy with mild myocardial interstitial fibrosis, stained in blue, and Mason trichome Swyton arrow in a patient with long-standing type 1 diabetes at autopsy with perivascular fibrosis and mild fibrosis between the myocytes. Also, gene expression is really very important, and he enhanced myocardial gene expression for muscle carnitine palmitotransferase. Down regulation of a fast isoform again is a real important. So this is the pathophysiological substrate of diabetic cardiomyopathy with anatomical damage of the myocardial substrate, atheromas, pathologic alteration of small coronary vessels, and the myocardial endothelial include increased cell adhesiveness, impaired relaxation, impaired fibrinolysis, increased permeability, and so on. So definitely diabetes has a lot of pathophysiological ways: hyperglycemia, free fatty acids, insulin resistance, all leading to vasoconstriction, to inflammation, to thrombosis, and definitely all are really very important. Diabetic hyperglycemia, dyslipidemias, inflammatory cytokines, all leading to abnormal metabolism, glycated in the products, lipotoxicity, extracellular matrix accumulation, cardiac dyshomeostasis, and apoptosis. All these leading to a lot of complications like beta-adrenergic signaling pathways dysfunction, cardiovascular autonomic neuropathy, abolished preconditioning. All this leads to diabetic cardiomyopathy. So we do have a lot of data. We have the fibrosis, a lot of what we said, that lipotoxicity, the mitochondrial dysfunction, altered insulin signaling, oxidative stress, inflammation, apoptosis, autophagy. All these leads to diabetic cardiomyopathy. So it is a consequence of metabolic disorders. All these leading to left ventricular hypertrophy, dilatation, and definitely fibrosis. And this is what they do, all forms of heart failure with preserved ejection fraction, with reduced ejection fraction, phenotypes again in restrictive heart failure with preserved ejection fraction. The phenotype cardiomyocytes are hypertrophied, and collagen is laid down in between the cardiomyocytes. The preclinical of detection is not efficient and is not very easy because molecular mechanisms are not fully elucidated. It remains asymptomatic for many years with comorbidities. Currently, diabetic cardiomyopathy is diagnosed by exclusion of known risk factors for heart failure, and physicians should rule it out the other potential causes of symptoms. So it depends upon. So we can see it's a complex interplay between different mechanism. It's a powerful phrase, chaos, the cardiometabolic chaos, because it's a complex, intertwined, and often unpredictable relationship between heart and diabetes. It depends upon the duration of diabetes, like glycosylated hemoglobin, the exclusion of very well-known causes of coronary artery disease, the patient age, and the other risk factors. If I put the subject in a nutshell, I say that the pathogenesis of heart failure associated with diabetes is due to coronary artery disease, ischemia, increased myocardial fibrosis, increased activity of the renin-angiotensin system, and impaired myocardial energy, decreased myocardial utilization, increased uptake of fatty acids, increased oxidative stress, mitochondrial dysfunction, inflammation, abnormal myocardial calcium handling, autonomic dysregulation, sodium retention. Definitely, we do have cardiovascular risk specific for diabetes. This is the microalbuminuria, the massive proteinuria, abnormal platelet function, fibrinogen level is affected, and the serum insulin. We can look at by resting ECG, by exercise testing, and look for the perfusion imaging, which is very important in many ways. We look for the clues, looking for structural changes, functional changes, by metabolic changes, by definite means. This is a dimensional echo, the diastolic functional changes, the diastolic dysfunction. We can newer advanced new techniques for echo. You can look for the tissue Doppler and speckle tracking, the affection through the mitral valve, and looking for the mitral valve affection cardiomyopathy associated. So a lot of GLS, a new strain pattern, reduced myocardial strain, the MRI, which is really very important. We do have stages of diabetic cardiomyopathies: the early stage, the middle stage, the late stage. What about the epidemiological trends and metabolism? This is the next part of the presentation. Cardiometabolic diseases, type 2 diabetes, obesity, cardiovascular disease continue to drive increases in mortality globally, particularly in populations with lower socioeconomic status or limited access to healthcare. And as we can see, this is the decoding health, exploring essential biomarkers needed for linked to metabolic dysfunction. A lot of biomarkers you can look for. You can see a lot of biomarkers, and definitely one of them is the glycosylated hemoglobin, the CK, the leptin, and the resistant insulin fasting glucose, the MREs, and a lot. What's going on? Heart diabetes access in the year 2025. Cardiometabolic chaos likely means the complex interlinked derangements in metabolism, cardiovascular function, lipid handling, inflammation that occur in diabetes and related metabolic disorders. A few recent findings are giving clearer mechanistic insights and pointing toward the new therapeutic angles. What about the recent advances? Now we are looking for new metabolic axis in diabetic heart. A major study by Heather Group has identified a molecular axis that helps explain why the diabetic heart accumulates fat, what's called lipotoxicity, and become dysfunctional. In brief, in diabetes, the fatty acid transporter protein CD36 becomes abnormally stuck at the plasma membrane in cardiac myocytes, increasing fatty acid uptake. This cause is altered post-transitional acetylation. So this is really very important. This gives a more precise molecular handle on how the diabetic heart becomes fatty, how that leads to contractile dysfunction. It also suggests potential for therapy. So we do have a potential for therapy, targeting lipid trafficking or post-translational modification in the heart. Again, the liver-heart axis. That's another recent paper decoding the liver-heart axis, explored the communication between the liver and the heart and metabolic disease, obesity, non-alcoholic fatty liver disease. The NAFLD, the liver is increasingly seen not just as an energy glucose regulating organ, but as an active player. It is not just an energy glucose regulating organ, but an active player in secreting factors like hepatokines, lipid inflammatory mediators that impact the cardiac structure function. For instance, the NAFLD correlates with worse heart outcome, independent of classical risk factors. So hepatic dysfunction or overnutrition can worsen myocardial metabolic stress. So this is the liver-heart axis, which is really very important. A definite relationship between the liver-heart axis acting the way as we have said. What about the clinical and therapeutic development? With better understanding of molecular axis, like the CD36 axis, there is a growing interest in early intervention, drugs affecting lipid metabolism, SGLT2 inhibitors, GLP-1 receptor agonist, intervention in obesity NAFLD, as well as the use of digital AI tools for risk stratification. Some of these are being integrated into guidelines and trials implied in meetings like heart and diabetes. Key challenges chaos. While advances are promising, the system remains highly complex. Still, it's very complex. Some of the reasons there is still chaos are still chaos. So multiple overlapping pathways, lipotoxicity, oxidative stress, mitochondrial dysfunction, changes in substrate use, glucose versus fatty acid inflammation, fibrosis, all feed into cardiac damage. So this is a really very important. Post-transitional modifications and regulation, again, a modification in lipidation that control protein localization function are really very important. Again, the systemic versus organ-specific effects. So the liver-heart axis, kidney involvement, adipose tissue inflammation, disturbances in one organ, often send signals. This in the form of hormonal, metabolic, inflammatory to others. And this makes the axis behavior non-linear, which is really very important. Heterogeneity among patients, not patients are the same because there is difference in genetics, duration of diabetes, comorbidities, obesity, hypertension, dyslipidemia, age, sex, social determinants. We have also the transitional gap. Many molecular findings are in animal cell models. Translating into safe, effective human therapies is always non-trivial. Also, timing matters because intervening before irreversible damage versus after. What to watch? Frontiers in the year 2025. Number one, therapeutic targeting of lipid trafficking, CD36 axis, drugs that module acetylation, enhance removal of internalization of CD36 or prevent its pathologic membrane anchoring, modulating this number one. Number two, modulating organ crosstalk. For example, hepatokines, lipids from liver, adipose tissue may mediate heart changes. Precision medicine. We're in the era of precision medicine. Not patients, all patients are alike, phenotyping, using biomarkers, molecular imaging to stratify who is most at risk or who will benefit from a specific intervention. What to watch frontiers in the year 2025? AI digital tools, because we have risk prediction models combining ECG imaging, metabolomics, and clinical data. Tools ECG Dianet are emerging for predicting diabetes, lifestyle obesity, as obesity and fatty liver contribute upstream interventions targeting weight loss, dietary quality, physical activity, bariatric surgery in appropriate patients. What about clinical trials? Trials that test earlier intervention, that measure the cardiac structure by using imaging like MRI, echo, as endpoints in metabolic disease. It's not just hard outcomes like MI or mortality, but subclinical dysfunction. To understand the socioeconomic and population health factors, because populations with lower education, socioeconomic status often carry disproportionate burden. So we need to do public health awareness policy to access the healthcare food systems as a part of the access in human population. My summary to this cardiometabolic chaos, decoding the heart diabetes axis, is about unraveling the tangled network. It's really a tangled network, connecting metabolic disease, especially diabetes, obesity, with heart health. Some of the most exciting recent work includes discovery of the FOXO1 and the CD36 acylation axis, giving molecular insight into how hearts in diabetes become overloaded with fat. It becomes overloaded with the fat, which is really very alarming. There is an increasing evidence for organ-to-organ communication, so a direct communication between the liver and heart, playing a crucial role, accelerating integration of clinical, epidemiologic, molecular, computational tools to stratify risk and tailor intervention. But big challenges remain that in translating these findings, managing heterogeneity, intervening early enough to prevent irreversible damage. My take-home messages is that cardiometabolic chaos in systemic is not just cardiac. New mechanistic insights are very important. The CD36 axis, the liver-heart axis, offer targets. Precision medicine and digital tools are reshaping prevention and therapy. There is a need for early intervention and equity in access. This is my greetings from Egypt, and I have to say again, Hastus hierarchy of needs, that's very important. Every one of us has his own needs, but definitely at the top of this triangle is personal growth and fulfillment and achievement, status, reputation, good reputation. So my real greetings are coming from you from Egypt, and this is Gamila Nasr, and thanks again, Professor Ines Shaltut, for this kind invitation. My greetings are due to in India. Thank you very much.
Thank you, Professor Gamla, for an excellent session on cardiometabolic chaos, decoding the heart diabetes axis. And I absolutely agree and endorse that it is no more simply a cardiac disorder. It is more of a systematic disease which needs to be handled. And there are huge challenges when you decode the heart diabetes axis as in 2025. So I'll request you to stay back till the end when we have some panel discussion. With that, we go to the second session, a very, very important session by none other than Professor Inas Sheltout. She is going to talk about sarcopenia and cardiometabolic risk, how important it is. She is MSc Internal Medicine, Cairo University. She is MD Internal Medicine, Cairo University, President of Arabic Association for Study of Diabetes and Metabolism, that is AASD, where we are partners together. She is Professor of Internal Medicine and Diabetes, Faculty of Medicine, Cairo University since 2004. She is also supervising MSc and MD thesis. Over 30 theses she has supervised over last 25 years. She is founder of Arabic Association for the Study of Diabetes and Metabolism, that is ASD, founder of Professional Diabetes Diploma by ASD in collaboration with New Gaza University, member of Egyptian Board of Internal Medicine Fellow Royal College of Physicians, UK. Our present work is Professor of Internal Medicine and Diabetes, Cairo University. There is a huge list of our credentials, so I'll not waste much time and invite Professor Inas Sheltout to do his deliberation. Professor Inas, madam. And we welcome Professor Mohammed also to this session. Over to you, Professor Inas.
About this important topic, sarcopenia and cardiometabolic risk. And sarcopenia is a Greek name, means lack of flesh. Sarcopenia is a newly recognized syndrome occurring especially in geriatric people. It is age-related loss of muscle mass and muscle function. Studies showed the association between sarcopenia and adverse health outcome in the form of falls, disability, hospital admission, poor quality of life, and mortality. Then it's important to diagnose sarcopenia to prevent and to treat. Against sarcopenia is lack of flesh, and this graph shows the loss of muscle mass and strength with aging and the percentage of muscle loss with aging, comparing those at the age of 30 to those at the age of 45 and 75 with maximum loss of muscle mass. After the age of 50, there is 1 to 2% of muscle mass lost per year. But after the age of 60, this rate increases to 3% per year, along with decrease in strength of 1.5% annually. These are the changes in body composition associated with aging. There is gradual decrease in muscle mass, especially those of lower extremities, and increase in fat volume, especially the visceral fat and the intermuscular fat. Depending on the definition of sarcopenia, the prevalence of sarcopenia ranges from 10 to 40% of the world population. Increasing lifespan over the past centuries, with consequent increase in the prevalence of adults above the age of 65, this led to increasing the prevalence of age-related conditions such as sarcopenia and diabetes. Individuals above the age of 65 will rise from 9.3% globally of the world population in 2020 to 16% of the total population in 2050, and we're going to have 1.5 billion elderly persons above the age of 65. This is the operational definition of sarcopenia done in 2018. We have 3 criteria. Criterion 1 is low muscle strength. Criterion 2, low muscle quantity and quality or quality. And criterion 3 is low physical performance. If there is only one criteria, then sarcopenia is probable. And the diagnosis is confirmed by documentation of 2 criterions. And if criterion 1, 2, and 3 all are met, sarcopenia is considered severe. And these are the possible pathogenetic factors for sarcopenia: decreased physical activity, endocrinal disorders, muscle atrophy, decreased protein synthesis, insulin resistance, mitochondrial dysfunction, autophagy, malnutrition. And sarcopenia is a multifactorial disorder, and these are some of the known causes of sarcopenia: decreased level of sex hormone like testosterone and DHEA, decreased level of growth hormone and insulin-like growth factor 1, increased cytokine production, interleukin-1, interleukin-6, tumor necrosis factor, neuromuscular changes, smoking, physical inactivity, and malnutrition, especially the protein malnutrition. What are the changes in muscle function in sarcopenia? There is preferential loss of type 2 fibers, leading to difficulty in walking, stair climbing, rising from a chair, gait problems, and load carrying deterioration. Loss of independence, increased risk of falls, and decreased basal metabolic rate, which leads to a condition called middle-age overweight. This figure shows the decrease in lean mass muscle associated with increase in the total lipid stores. We can find the muscle mass decreasing. The color is dark or black. Then the fat stores are increasing. We have loss of muscle mass and decrease in muscle mass by age, and increase in fat stores by age. This is a comparison between those at the age of 20 up to the age of 79. And again, this figure shows the muscles before and after sarcopenia, and comparing muscle of an average healthy adult to the left side to another person. The muscle is after sarcopenia, and we can see here loss of muscle mass and increase in fatty tissue. And when we differentiate sarcopenia from other diseases of the muscle, sarcopenia is not wasting, because wasting means loss of weight due to inadequate nutrition. And sarcopenia is not cachexia, because cachexia is loss of fat-free mass from hypermetabolism and hypercatabolism. While in acute disuse atrophy, the muscle mass is reduced, but the fiber number and force is maintained. The vulnerability of sarcopenia is augmented in patients with type 2 diabetes. For example, older women with type 2 diabetes are at high risk for loss of skeletal muscle mass. So, what is the relation between sarcopenia and diabetes? And this shows how insulin resistance causes sarcopenia. Insulin resistance can play an important role in sarcopenia pathogenesis by reducing muscle, by inducing muscle attenuation, by increased protein catabolism, and decreased protein synthesis in the skeletal muscles. Type 2 diabetes is characterized by insulin resistance, chronic inflammation, accumulation of AGEs, advanced glycated end products, and increased oxidative stresses, All these factors can negatively affect the skeletal muscle mass, strength, and function, leading to sarcopenia. Again, compared to non-diabetic patients, diabetic patients have decreased muscle mass and higher prevalence of sarcopenia. And also the reverse, patients with sarcopenia may be at increased risk of developing diabetes. There is a reciprocal relationship between diabetes and sarcopenia. Sarcopenia prevalence is 2 to 3 times higher in diabetic persons compared to healthy controls and vice versa. The factors implicating both conditions, they contribute to both sarcopenia and diabetes relationship, and those factors include insulin resistance, altered metabolism, advanced glycated end products, advanced age, increased adiposity, obesity, inflammation, oxidative stresses, mitochondrial dysfunction, vascular complications, muscular atrophy, reduced muscle quality and function, myopathy, and lifestyle changes in the form of lack of exercise and unhealthy diet. And these again are factors happening in both sarcopenia and diabetes, and each of them can lead to the other: aging, genetics, mitochondrial dysfunction, oxidative stresses, advanced glycated end products, poor diet and poor nutrition, sedentary life, lack of exercise, and stress. All these factors can lead to both sarcopenia and diabetes. But we have other groups of factors leading to sarcopenia and other groups of factors leading to diabetes. And here in this figure, there is the consequences of each of those two diseases, sarcopenia and diabetes. How to screen for sarcopenia in older individuals? First is to measure the gait speed. If the gait speed is less than 0.8 meter per second, we measure the hand grip strength. If normal, there is no sarcopenia. If low, then we shift to the other method of diagnosis. When we can find the gait speed more than 0.8 meter per second, we measure the muscle mass. If low muscle mass, then there's sarcopenia. If normal, then there is no sarcopenia. Sarcopenia leads to potential health concern, and the rate of decline in strength of the muscles are twice in men compared to women. Men on average have large amount of muscle mass. Another cardiometabolic disease, which is hypertension, it is a major public health problem, and hypertension is linked to insulin resistance, again, which exacerbates the loss of muscle strength. Insulin resistance leads to hypertension through several mechanisms, among them enhancement of tissue angiotensin II and aldosterone, increased sympathetic nervous system activity, oxidative stress, a new phenomenon known as endothelial insulin resistance. This study showed the prevalence of factors associated with sarcopenia in elderly individuals with hypertension, and this study result showed that there was very high prevalence of sarcopenia among elderly individuals with hypertension, reaching 20% of cases. Current research confirms that sarcopenia is associated with hypertension. The possible mechanisms linking hypertension to sarcopenia, the production of related catabolic cytokines, chronic inflammation, and associated catabolic factors. These are most widely accepted mechanisms of sarcopenia. Muscle mass and function decline with age. This is considered a normal phenomenon, but it can rapidly progress when there is a chronic condition such as hypertension. And this is again the relation between cardiovascular disease and sarcopenia. Both can be affected by malnutrition, physical inactivity, insulin resistance, inflammation, hormonal changes, autophagy, apoptosis, and oxidative stress. We come now to the end of our presentation and how to treat sarcopenia. First, we should try to prevent sarcopenia by regular exercise from early life. Then to treat sarcopenia by exercise in the form of resistance exercise to prevent or reverse muscle loss, aerobic activity, walking, cycling, golfing, and swimming, lifestyle modification, nutritional modification, increased protein intake, less carbohydrate, and increased fiber intake. Stress-free environment whenever possible, and functional and active daily schedule. Thank you very much.
Thank you, Professor Inas, for a wonderful presentation. And I'm sure what you really said is that sarcopenia is not only the age-related thing, and it is possibly a modifiable risk factor for development of pre-diabetes, diabetes, and cardiovascular risk. Only thing is we need to start exercises quite early in the course of life so as to avoid sarcopenia, because especially as we age, sarcopenia tends to even worsen, especially if we have not been exercising from early days, and that itself increases the risk of developing not only diabetes but overall cardiovascular risk also goes up. So I'll again request you also to please stand by for the discussion toward the end. And with that, we go to the next session, that is by Professor Antonio. I do apology that he may not be able to log in because he has some family commitment, but he has been kind enough to send his recorded session. It is on metabolic memory is back. So can I have Dr. Antonio's CV? RX people, can you display his CV? Neelam, please display the CV of Professor Antonio. Yeah. So it is a pleasure to have Professor Antonio's session recorded, and we are going to play that during this symposium. Professor Antonio has published widely in the area of diabetes with over 500 original papers with an H index of 108, which is very, very high. Currently, he is the president of European Association for the Study of Diabetes, study group on diabetes and cardiovascular diseases. He has also served as board member of 2019 European Society of Cardiology guidelines on diabetes, pre-diabetes, and cardiovascular disease, developed in collaboration with AASD. From July 1st, 2016, he has been appointed as editor-in-chief of Diabetes Research and Clinical Practice, the official IDF journal, a very, very prestigious journal everyone is looking for publishing in these journals. And Professor Antonio is the winner of 2004 Camilo Golgi Prize of AASD and of 2017 of Helmut Ment Award during IDF 2017. So without wasting much of the time, we'll straightway go to Professor Antonio's session, which is on metabolic memory is back.
Hello, everybody. It's a pleasure to be again together with you, even only through the web. Unfortunately, I have another engagement and it's impossible to join you in Delhi. My talk today is focused on the metabolic memory, which is a well-known phenomenon, but we have very interesting news to share. That is why the title of my presentation is "The Metabolic Memory is Back." These are my conflict of interest. So we, some years ago, we defined the metabolic memory as no more than just tight glucose control necessary to prevent diabetic complications. Why? Because we got epidemiological and prospective data supporting a long-term influence of early metabolic control on the clinical outcomes, and in a way that the early glycemic environment is more or less remembered in the target organs, very important target organs. You see eye, kidney, heart, extremities. So the metabolic concept, the concept of metabolic memory is of diabetic vascular stresses persisting after glucose normalization. And we know, who is working in diabetes field, know very well from which kind of studies this concept was coming out. First of all, from the DCC-EDIC study, which was the first study showing that optimal glycemic control in type 1 diabetes can reduce the risk for complications, including cardiovascular complications. And in the EDIC study, which was the follow-up of the DCCT, it emerged that even the people who were at the beginning of the trial treated in a less intensive way, were anyhow rescuing some improvement in the risk for complications, in the follow-up, anyhow, they were remaining at higher risk for complication compared to who was treated from the beginning in a very intensive way. And this concept was further confirmed in the UK PDS, which was able to confirm that good glucose control can prevent complications, but now, this time in type 2 diabetes. So this slide helps to better understand the meaning of the effect of a delayed intervention. You see here that patients who were not receiving an optimal glycemic control in time, in years, still have a worse prognosis for the complications. This concept can explain why the results of the UK PDS were so different from the results of some trials. You remember the Accord, the VADT, and the Advance, where the plan was to show that an intensive control can prevent complications, but these trials failed. And the idea behind is that while in UK PDS, people were treated intensively at the beginning of the disease, this was not the case for these trials. You have here the example of the ADT, when the intensive control was started almost 10 years later the diagnosis, of course, all the time to establish the metabolic memory was already there. But how long can persist the effect of early bad glycemic control? For example, in type 1 diabetes, from the EDIC study, for the follow-up of the DCCT study, the EDIC study, we have evidence that even after 30 years, this difference in the pattern for the complication is still there. And you see any kind of complications, micro or macroangiopathic complications. And no different is the situation for UKPDS. This paper published a few years ago, you see here in the UKPDS what was the outcome when people were able to reduce of 1% A1C after some, let's say, some different years. You see here from the diagnosis, or after 5 years, or after 10 years of the diagnosis. You see the effect on the risk of complications was completely different. Later started the good control, worse was the prognosis. And more recently, we have a 24-year follow-up of the UKPDS, confirming that in type 2 diabetes, even after 24 years of a follow-up, who was treated intensively from the beginning, still shows a better outcome for any kind of complications. So very impressive result. 24 years is a very long period of time, of course. But to better understand the pathophysiology of metabolic memory, we need to have a look at what is supposed, or let's say now well demonstrated, we can say, the cause of diabetic complications. You know that the studies coming from Michael Brownlee group and by my group were able to confirm that there is a unique pathophysiological mechanism linking hyperglycemia and diabetic complications. And this is the overgeneration of free radicals at the mitochondrial level. You see here that according to Michael Brownlee work, you see that this is enough in activating the major pathways involved in the pathogenesis of diabetic complications. And according to also to our work, you see that we discover the other pathways complementary to those of Brownlee, further explaining how oxidative stress is linked to the pathogenesis of diabetic complication. So we were wondering if oxidative stress is the main cause of diabetic complications and the metabolic memory means an increased risk for complications, is oxidative stress also involved in the mechanism of the metabolic memory? And we settled this kind of design. You see, we were culturing human endothelial cells in continuous normal high glucose, or of course normal glucose as control, but also we switched the cells after 2 weeks exposure to high glucose to normal glucose, just to mimic the possible effect of the metabolic memory. And what we found is that we had, first of all, strong evidence that the increased production of compound related to the pathogenesis of diabetic complication persisted even when we were switching cells from high glucose to normal glucose, and that oxidative stress was involved. You see here that we had some markers of pathways involving oxidative stress, like P47 FOX, 3-nitrotyrosine, OPAR, or pathways involved in the oxidative stress generation. And this was also confirmed in a different way, meaning if you were using different approaches for blocking the oxidative stress, the most powerful effect in decreasing the effect of metabolic memory was obtained using antioxidant specific for mitochondria. So we were able to demonstrating that first, oxidative stress is involved, and the second, if you block specifically mitochondrial generation of oxidative stress, you abolish the metabolic memory effect of hyperglycemia. So, for sure, we can say that these pathways are engaged, but if you see at the pathways activated by the overgeneration free radicals, we also have the overproduction of AGEs, particularly in the cells. And we have evidence that the age, when are linked to own receptor, RAGE, they are also able to overactivate intracellular oxidative stress. So this amplifies the effect of hyperglycemia. And also not in a way directly related to age, but also when the proteins of mitochondria are glycated, they overgenerate free radicals. So at the end of the day, we have very strong, clear evidence that the mitochondria is the key player also in producing the effect of metabolic memory, probably inducing a DNA change, epigenetic changes, which can last longer and inducing a high risk for oxidative stress. Why I spent some minutes to explain the role of oxidative stress in the metabolic memory? Because until now, we knew that to abolish the metabolic memory, the only way was to optimize blood glucose control from the beginning of the disease. But because we know what is behind, meaning oxidative stress over generation, it's really intriguing to understand that if it's possible to do something except the optimal glycemic control to avoid the appearance of a metabolic memory. And we were intrigued by the recent evidence that SGLT2 inhibitors are able to control. I think that this concept is not yet so clear, so well, let's say, recognized. But the SGLT2 inhibitors are able of modulating in a favorable, in a good way, the increase of antioxidant defenses against oxidative stress in the cells. So they have the potential of counteracting the metabolic memory appearance. And because in the UK PDS, as of course also as well in DCCT, this drug were not available, we were wondering, are SGLT2 involved having the power of inhibiting the metabolic memory in type 2 diabetes? And then we used a huge database from Italy, the MD Annals, which is following more than 500,000, more than 1 million people for more than almost 20 years now. And you see here that we were including people who were having or not SGLT2 therapy starting from within 1 year from the diagnosis, 2 years from diagnosis, or 3 years from diagnosis, and who were free at the beginning, at inclusion of any kind of complications. And we were looking at the 3-point MACE outcome in this population. First of all, we were able to confirm the presence of the metabolic memory in our cohort, you see here. But the most intriguing result was to show for the first time that if you have on board an SGLT2 within 2 years from the diagnosis, you can avoid the appearance of the metabolic memory. Why 2 years, not 3? Of course, this is quite intriguing. Probably is a limiting effect of the epigenetic changes, the possibility to reverse the epigenetic changes of the DNA. This is not unclear, of course, at the moment, but clinically, this is very relevant because confirms that we have the chance to avoid the appearance of the metabolic memory, introducing an SGLT2 very early in the treatment of diabetes. And so is why the conclusion of this paper was that these findings advocates a wider and early use of SGLT2 inhibitors. And from China, last year, our findings was confirmed. But because the database of the Chinese was huge and larger than our database, they were able also to show, using the same approach we used, they were able to confirm the effect of SGLT2 within 2 years from the introduction to the therapy, but also, and this was new, the possibility that also the GLP-1 receptor agonist can give you the same effects, which is not surprising because the GLP-1 receptor agonists also are able of modulating the intracellular defenses against free radicals. So we have now good news because these new drugs not only are beneficial for many, many effects, as we know very well now, but the possibility of an early introduction of them in the therapy in order to prevent the appearance of metabolic memory is really an important news. This concept that good glucose control should be started as early as possible to delay or prevent serious diabetes-related complications was claimed by Alan Charrington in 2005 during an ADA Congress, when the first data on the metabolic memory in the DCCT edict were shown. And at that time was a revolution, meaning, an early good control can really help to prevent serious diabetes-related complications. And we, today, we are a step ahead because not only a good glucose control, but also an early introduction, particularly of SGLT2, can really help to avoid the appearance of metabolic memory that, as we learned today, can last for a very long time, even decades. So let's also spend a few words about the new concept, because when we speak about the targets, we are looking at the targets of A1C of 7%, which occurs in the terms of avoiding metabolic memory, controlling in the best way hyperglycemia is very relevant. But we were able to publish a few months ago that this concept of 7% probably is not so good. Because again, using the Italian database, we were able to show that if you are lower than 7%, particularly between 5.7 and 7%, still you have an increased over risk for diabetic complications, which means that 7% probably is not the ideal target. Of course, could be a compromise in order to avoid hypoglycemia and so on. But with these new drugs, showing a so low risk for hypoglycemia, probably we can work better and we can choose a lower target for A1C. But the other problem is that metabolic memory is induced not only by high constant hyperglycemia, but also when you have a glucose variability, this also can induce the metabolic memory. So we also have to, probably we need to lower the glucose variability also to improve the possibility to avoid the metabolic memory. And you know that the glucose variability is now considered a very strong independent risk factor for any kind of complications. And finally, the last horizon is the existence of metabolic memory also for obesity. It is really important to know that when people are losing weight, their adipocytes do not like at all this. They have this, they retain the epigenetic change in order to, let's say, to force people to eat in order to regain the weight. Probably this is one of the mechanisms which favor weight regain when people are losing weight. This is a new field of a very important field of research to look at the obesity-related metabolic memory, which is the new frontier for the treatment also of obesity, of course. And you know that this effect of metabolic memory for obesity can produce a body weight variability, but meaning the so-called yo-yo effect, which has been shown many years ago to be a very strong independent risk factor for cardiovascular disease. And we were able to confirm that this is true also for diabetes. So any body weight variability can be very dangerous for the people with diabetes. And the last message is that probably we have a sort of a memory also for some other risk factors of cardiovascular disease. You know very well the STINO study, able to show that intensive control of risk factors for CVD can prevent the appearance of the complications. But this was also a recent report reported that this disadvantage can persist after years. So again, what do we do at the beginning in controlling in the best way all the risk factors, not only glycemia and body weight in type 2 diabetes, can be really helpful for our patients to prevent in the long term the appearance of complications. Thank you very much for your attention.
Thank you, Professor Antonio, for a wonderful session on metabolic memory. It is back. Unfortunately, we couldn't have you physically in Delhi, which you promised, but because of your family commitment, you couldn't make it. But you have been kind enough to produce this recorded session and message for us, and it is so grateful. And we want to put it on record that your contribution in this scientific session will go a long way in getting a lot of learning amongst our delegates. And you very rightly highlighted 3-4 things. One, that it is the metabolic memory, which is back, and it is early days. We said it is only the glycemic control achieved early in the course of the disease, which was a long way in prevention of micro and macrovascular complication. Of late, we understood that as long as we can prevent hypoglycemia, achieving metabolic memory and a tight glycemic control with drugs like GLP-1 receptor agonist or maybe SGLT2 inhibitor will even go a longer way in preventing cardiovascular morbidity, mortality, 3-point MACE, and many renal outcomes if these are achieved with these drugs as compared to drugs like sulfonylurea or old conventional drugs. And last point, you said that it is the mitochondria which is the reservoir of this metabolic memory, which ultimately reflects in the form of epigenetic changes. And if you have had a tight glycemic control with drugs which have pleiotropic benefits like SGLT2 inhibitor or GLP-1 receptor agonist that will even go a longer way. Earlier it is achieved within the onset of maybe 6 months or 1 year of the disease, better are going to be the outcome. So thanks a lot. Once again, we put it on the record that we had a wonderful session by you, and we express our gratitude that in spite of your very busy schedule and your family commitment, you could make it. With that, we go to the last session of today, that is by Professor Mohammad Hasnain. He's going to talk about pre-diabetes and obesity, the link, the challenges, and the way forward in that. Professor Mohammad Hasnain is at Mohammed bin Rashid University, Dubai, senior consultant in endocrinology and diabetes at Dubai Hospital, and he is also professor of medicine, Gulf Medical University, UAE, co-founder of Diabetes Diploma, MSc for Cardiff University, UK since 2007. That is how we got associated with him almost 12 years ago, and we were actually the only course director, me and Dr. Shalini, in this part of the world for running those diabetes diploma courses from Cardiff University. He is also consultant in the Department of Endocrinology and Diabetes at UK. In 2002, he graduated from the Faculty of Medicine, Alexandria, Egypt. His main research interest is in the field of diabetes and Ramadan, and he's ex or past president DAR group, that is Diabetes and Ramadan group. He co-authored recommendations paper on this subject for American Diabetes Association also in 2005-10, and for the British Medical Journal in 2010, and Diabetes Canada in 2017, as well as IDF DAR practical guidelines in 2016 and 2021. Minded, these are wonderful documents if you have gone through it, and these are sort of standard care today once you go through these DAR practical guidelines. Other area of interest have been educational program for people with diabetes, and for HCP, where he won the first prize for this from Diabetes UK and AASD, and he has participated as first author and a co-author in numerous studies, regional and international guidelines, including studies on prevalence of diabetes, obesity, hypertension, and is a first author for many of these publications in Emirates cardiometabolic guidelines, and he has published over 100 papers. To us, he is a core committee member of organizing committee of CMRE AASD International Symposium. Almost 12 years we have been together, and I always say that in spite of different ethnicity, we are probably more than brothers when it comes to supporting a program. He has been a backbone of our entire initiative of CMRE since early days with Cardiff University. Subsequently, he then joined us, and now through ASD along with Professor Enas, they have been our partner for more than 6 years. Over to you, Professor Mohammed. Nilam, is there any issue? Team RX,
Yes, sir.
please start a session.
Yes, sir.
What is the problem?
If you're having problems, I can do it live.
Yeah, he can do it live.
Better, sir, you do it live only. That's always better.
Okay, no worries. Okay, so good evening, everyone. It's great to be with you, though virtually. I'm looking forward to meet many of you tomorrow live in Delhi for the continuation of this excellent program. It's always a pleasure to work with my very good friends, Dr. Rajiv Chawla and Dr. Shalini Jaggi, and also the collaboration with my friend and sister, Professor Inas Chaltud, and many of the professors from the AASD. And certainly it was a pleasure also to hear the presentation of Antonio Cirello, one of our eminent friends and colleagues. So my topic regarding prediabetes, obesity, the link, the challenge, and the way forward. Now, it's not a surprise that you all see, whether it's in Egypt, India, or Dubai, or globally, that the prevalence of diabetes is more than doubling over the last 20 years or so. This is data from where I currently work in Dubai, and we've done a WHO House Health Survey. And as you can see, in green is the whole population who are living in Dubai. And actually, Dubai, only 1/8 are local population, and 7/8 are from other countries, including, of course, a massive percentage from the Indian subcontinent. So this is the data of the full country and not just of Emiratis. And as you can see, roughly about 60% are overweight or obese. This is very recent data that we've published earlier this year. My colleague Amin Abdul Qadir, as well as many of us, have looked into the database that we have in Dubai Health. We have electronic medical records, and this is the record of anyone who went to any health facility for whatever reason. And as you can see, it's very unfortunate that we are now talking about 30% of young boys and girls, or even more than 30% in the case of girls, who are overweight or obese. Now, obviously, this is a very big concern, because if it's 30% now, or a third of them now, then what will be the situation when they are in their 50s or 40s, or indeed even their 60s and beyond? So it's quite a concern, because when I also reflect on the data from my home city, Alexandria, and this is a study that we've published with many of the professors from Alexandria University looking into prevalence of diabetes, the prevalence is pretty high, and the prevalence of obesity is also pretty high. The government of Egypt have recently done an initiative called 1 Million Health, which meant that 1 million persons to be screened for non-communicable disease. The data are published as a document, and that was in 2019, so 5 or 6 years ago. And looking into obesity in Egypt, unfortunately, we even have worse data than what we saw in Dubai. Only 35%, so 40%, so kind of more or less similar, because we have the distribution here of people who are overweight is quite high. Even significant obesity is quite high as well between men and women. If you look into specifically into ladies, if you look into the BMI of the average BMI was 35.7, and above the BMI of 30. So this is obesity, not just overweight. This was nearly 50% of women and 25% of men. While men's weight was a bit better, smoking was vastly worse, with 43% of men reporting to be smoking. I probably think that the 0.5% of women smokers is an underestimate, because in our cultures, not many women like to confess that they are smokers. But when you look into physical activity, 96% of women are not engaging in physical activity, and 63% of men. When you look into the classic Egyptian food was full of fruits and vegetables. probably similar to the Indian food. But now, unfortunately, people who are saying they are eating less than the 5 servings a day of fruit and veg is 90% of either men and women. So what has happened? Why have we changed? I think the recognition of obesity as a health problem made us collect more data, the type of food, the quantity of food, and certainly the sedentary lifestyle. I've managed to get from the net pictures from my home city, Alexandria, where I currently live, Dubai, as well as Delhi, 60 years ago, as well as recent photos. And you can see for yourself the massive difference on the roads. This urbanization has came with a price. Certainly increased the sedentary physical activity. Yes, of course, there is an improvement in economy, but that came with more of the junk foods, which has an impact on glycemia, blood pressure, and lipids. So the two twins, obesity and type 2 diabetes, unfortunately, are the son and daughter of this urbanization and change in culture. We know that obesity has a very strong link with metabolic problems, which also have an impact on cardiovascular disease. And this is what in red, what I've highlighted to be direct link of obesity and metabolic and vascular risk factors. And it's very interesting when you look here into any of the vascular risk factors in relation with the weight as well as with the metabolic status. So whether it's coronary heart disease, cerebrovascular disease, or heart failure, and when you look here into overweight and obesity, the presence of one metabolic or cardiovascular risk factor is a risk, but obviously when you increase the number of risk factors, it becomes even higher and higher. We all very well know the mirror image between obesity and diabetes. So if we focus on India and the MENA region, obesity in India is a bit better than the Middle East. However, diabetes is not much better. You can see that, unfortunately, we come from regions with high prevalence of obesity, and the mirror image of it is high prevalence of diabetes as well. This was very evident from the data that we've collected for the household survey, both of 2014 as well as 2019. And here is the correlation of BMI as with prevalence of diabetes. So in people with normal BMI, it was about 8.2%. In people with obesity, it was 21.5%. Very, very striking evidence. And the same with prediabetes. When you look here into the prevalence of prediabetes in people with normal BMI is 6.8, and then in people who are overweight is about 4 times, nearly 4 times higher, and if it's obesity, it's 2.5 times higher. But the question is not just about obesity, it's where the fat is. Are you having the fat centrally, what we call the apple shape, or a different pattern similar to the pear? Many men have the apple shape and many women have the pear shape. And there is a big difference between the two. As you can see here, the apple shape is much worse. Having central obesity is a lot worse type of fat, which can lead to more problems. So fat cells are not inert cells. They're not such simply pieces of fat. They exert a lot of metabolic harmful effect, primarily with the increased free fatty acids and inflammatory factors, adipopykins, and of course, all this can lead to abnormalities in glucose metabolism, hypertension, dyslipidemia, and these are the precursors for atherosclerotic vascular problems. Central obesity, when we looked into the data in Dubai, has also been pretty high, a bit more high in nationals as compared to non-nationals, and a lot more higher in women compared to men. When I look into data from Abu Dhabi, which is the capital of UAE, and this is data from 55,000 persons who registered into this insurance scheme, and part of the registry was to collect all the parameters. And in younger age, men look to have more central obesity, but as we get older, it does look like women who are looking after their waist circumference, perhaps that gets relaxed a bit. So in the 60s and beyond, the level is equivalent. So the problem also is many people who are obese, they're not aware that they are having a weight issue or a disease. So 68% only of people with obesity recognize obesity as a disease. And obviously, the vast majority of healthcare professionals, but it's still a problem because 12% of healthcare professionals did not recognize obesity as a disease. Now, the good news is, if we are to reduce the weight, we can reverse or halt many of the metabolic problems. Look here into the data that shows that if we are to lose 10 to 15% of the body weight, we can end up with type 2 diabetes remission. Indeed, prevention of diabetes, pre-diabetes to converted diabetes, is very much related by losing over 5%. And if we go up to 15%, that definitely will be the case. Plus, many of the other health-related problems that really improve vastly with weight reduction. A key factor in controlling weight is physical activity. The classic is that we need to walk 10 steps a day, 10,000 steps a day. I mean, it would be very good if it was only 10 steps, 10,000 steps a day. But not just the aerobic exercise that is important, we also need to start thinking of anaerobic exercise. Because as Professor Sheltut mentioned in her earlier talk about muscle loss and sarcopenia, anaerobic exercise helps to protect the muscles which are core in the issues related to diabetes and cardiovascular risk. Are we doing this level of exercises? This is data from the Dubai Household Survey that we published a few years back. And we asked people here about moderate intensity. The definition of it was 10 minutes spent during different types of physical activity of work or even housework. Who was doing it daily? Only 17%. When we asked people about 10 minutes of a bit more intense physical activity, such as maybe playing football or cricket, it was only 5%. So clearly, we have a problem. Indeed, when we extended the question in another survey across the MENA region, and we asked people about their physical activity, 22% considered themselves inactive, and 41.7% considered themselves as low. So when you add them together, you are talking about roughly 2/3 of the type 2 diabetes population from MENA region are considering themselves either inactive or with low physical activity. This is an aerial shot from Google Map from my home city of Alexandria. And what you see here in green is two of the social sporting clubs, so sporting clubs as well as social clubs. So one is called Alexandria Sporting Club, the other one is called Samuha Club. And as you can see from the date where they were established, one was established in 1890 and the other one was established in 1948. Now I can assure you that the city population has grown 3, 4, 5-fold since then, but unfortunately, these are still the only two places where people can go and play sports and socialize in a more healthy circumstances. So consequently, when you look into the impact of physical activity on prevalence of diabetes, exactly the mirror image of obesity. Those who are exercising, the prevalence is 8.8. Those who are not exercising, it is 20.1. The mirror image of obesity versus normal weight. So clearly we need to do something. What can we do? What are the challenges? How can we motivate a person? How can we educate them regarding the importance of change in lifestyle? And very importantly, the buzzword is sustaining that change. So have a look here at the Look Ahead trial, this fantastic study that my very good friend, Professor Osama Hamdi, was one of the investigators. And what they've done in this study, it was really remarkable. But I want you to focus on what were the intervention. They wanted people to lose and maintain 7% of their weight through reduced caloric intake and increased physical activity. And the physical activity was 175 minutes of moderate intensity physical activity per week, and the calories were between 12 to 1800 calories per day. Some were able to sustain this, while others were not able to sustain it very much. So those who lost the weight over here, as you can see, the time scale is 16 months, 5 years. So can it be done? Yes, it can be done. But unfortunately, as you can see here, not many are in the green, many are in blue, or indeed are in red. And the question is, why? Well, I will come to the why a bit later, but I want to reflect again on the data from Dubai. When I look into what is happening over 2005 to 2019 with physical activity as well as eating the right type of food, you can see that adequate intake of fruits and veg is going down from 53% to 36%. So no wonder obesity has increased from 24% to 39%, and because the physical activity has remained more or less around the 20% mark. So the prevention plans are really quite important, but how can we achieve it? Now, all the guidelines are saying that you have to look for people with prediabetes and offer them intensive behavioral lifestyle intervention program. It's not good enough to tell me, go and change your lifestyle, or you have prediabetes, or you're obese. My response is, I've seen the mirror today. I don't need a doctor to tell me that. I need the structured education lifestyle program. We did the same in the Emirates guidelines. We said 6 months of intensive lifestyle modification before we start on therapy. But unfortunately, we have the therapy, but we don't have the intensive education program. And that is rather sad. So when you look into the studies that looked into prevention of diabetes, again, it's similar to the Look Ahead. Intensive input by nutritionists, by voluntary groups, by expert lectures, low-fat cooking sessions, visits to local supermarkets, phone calls and letters, education as well to the spouse of the person, and offering free of charge gym and exercise with motivators and exercise competitions, as well as voluntary walking groups and hiking. So going back to Look Ahead, first year, very nice reduction of weight, very nice reduction of waist circumference, very nice increase in physical activity, and very nice improvement in HbA1c. But then after the first year, much of this has lost. Why? Because unfortunately, in the study, the intervention was just for 1 year. And if you stop the intervention, then whatever you've done good is gradually lost. So this is really the crunch of sustaining the problems, of sustaining the profile. This is what the IDF have said, along with the European Connected Health Alliance, on what is considered to be the right place, the right city to live in to have the right prevention of diabetes efforts. You need to have sustainable outdoor facilities. You need to have access to healthy food. You have to access of drinkable water. You have to have education on healthy choices in schools, and you have to implement prevention policies, and you have to have accessible information on healthy choices. Unfortunately, not much of this is available in many places. And it is not just requiring the efforts of physicians. It needs Ministry of Health health authorities, insurance firms, ministers of education, trade, sports, the media, diabetes society, whether they are local or international, the pharmaceutical industry, because unfortunately the very effective drugs for obesity are pretty expensive, and many more. We obviously need prevention programs that are evidence-based and culturally sensitive, and obviously has to be acceptable to all ages and accessible to the majority of those at risk. And definitely, we need long-term plans, specifically thinking of the adolescents and the children who we need to prevent the weight gain and address this problem in the very early stages of life. So my last slides, ladies and gentlemen, consider this as a wake-up call, because what we know is that the prevalence of diabetes and pre-diabetes is pretty high, and it is very much related to obesity. I cannot change age, but I can change obesity and physical activity. And certainly we need urgent structured plans that can address the large scale of the population to prevent this serious health problem. And finally, I'll leave you with pictures of my beloved city, Alexandria. Thank you, and happy to take questions.
Thank you, Dr. Mohammed, for an excellent session as always. So let me start with the panel discussion with a funny question to you. You very rightly said that today it is the obesity which is the driver of rising prevalence of pre-diabetes, type 2 diabetes, and maybe NCD, at least in third world countries, more so in our Asian ethnicity also. But why then every obese person does not develop pre-diabetes or diabetes? Is it something to do with ethnic risk? Is it inheritance which matters? Is there still the concept of having a healthy obesity which may counter the risk for developing type 2 diabetes or cardiometabolic risk?
Well, I suppose it's a blessing that some people with weight issues do not develop diabetes. Otherwise, the problem would have been much higher, because the prevalence of obesity is far much more than the prevalence of diabetes. Of course, genetic plays a role. The type of obesity, as I mentioned in my presentation, also plays an important role. It's like anything else. So there is a large number of smokers. Not everyone would develop cancer, lung cancer, or heart or cardiovascular disease. So the genetic makeup of some individuals, whatever else they are doing, maybe helps to prevent the problem. And I think it's very important that we try to understand every culture who are at risk of developing the problem. My slight concern with this is that some people, if they know that I'm not, if we can do the genetic testing, who know who is at risk and who's not, then are we going to be relaxed about it and maybe say, I don't have the gene, I'm going to have the junk food and doesn't matter?
Yeah, that is other side. I think lighter side of that aspect, that today when we talk about precision diabetes, we normally have discussion with Dr. Mohan. You have also been working with him, that we are talking of precision diabetes and precision medicine. And when it comes to predisposition and predicting that someone is at a greater risk for cardiovascular disease or diabetes or pre-diabetes, even if he is obese or just overweight, will that sort of what you rightly said, take away the burden that someone who is not genetically predisposed may do anything and will not develop diabetes. Other end is that even if you don't have too much of prediction for developing diabetes or cardiovascular risk and you tend to be obese, still you need to continue with all the efforts so as to cut down that increased risk, which is definitely linearly there with development of diabetes moment you start getting weight. And in our own ethnicity, anything more than 23 to 25, in between you start sort of increasing that risk to a much greater level as compared to the Caucasian population. So shall we start with Dr. Gamila? She talked about cardiometabolic chaos, decoding the heart and the diabetes axis. Is she there, Dr. Gamila? Professor Gamla, are you there? Because she was the opening batsman, so might be okay. We go to the second speaker, Professor Enas. She said that sarcopenia definitely puts you on a higher CV risk. But I asked that time also, is it only the age-related sarcopenia which is important? Because we know that as you age, your physiologically also your carbohydrate metabolism gets delayed or slowed, and you tend to have some degree of dysglycemia as you age. But do you think it is primarily the age-related sarcopenia which puts you at a greater CV risk or a cardiometabolic risk, or even the younger people, those who are not exercising, those who are otherwise obese, but they don't have much muscle mass, they are also at a equally high risk for developing cardiovascular disease? Professor Inas, madam.
Um, you said a valid point, but I think it's not just age. The presence of inflammation, of inflammatory markers, of insulin resistance, of chronic disease like diabetes, then we may have many pathophysiological defects happening due to sarcopenia. Because you can find sometimes people at the age of 75, for example, and they don't suffer from sarcopenia at all. And sometimes we have younger population with loss of muscle mass and muscle power.
True. And in the first session, we said it is the fat mass or the adipocyte, which is an endocrine organ. Will you like to modify that statement that it is here the role of muscle or the ectopic fat inside the muscle is also very, very important. So that puts muscle in the central position, then only the ectopic fat or the adipocyte as an endocrine organ.
With age, muscle mass is reducing and the fat content is increasing, especially the abdominal fat, for example. So we need to maintain the muscle mass by age. We need to start. You said also this from the beginning. We need to start with exercise since young age to prevent sarcopenia better than treating sarcopenia. But it can be managed if it's not too late to start exercise at any age, even after 80 years age.
So you advocate only building muscle mass through improvement in physical level of exercise, both aerobic and anaerobic exercise, or muscle strengthening exercises, because in many gyms these days, unfortunately, younger people or younger adolescent, they tend to consume a lot of protein, very heavy protein with some anabolic hormones composition to build their muscles, and I'm sure they don't reduce their cardiovascular risk. What is your take on?
Taking too much proteins is not healthy at all. It can lead to hazards like renal impairment. Sometimes we saw some young adults with early renal impairment due to increased protein consumption. Really, I advise the normal protein in food. It's better not to take those tablets. They take a bunch of tablets every day of protein, creatine, and amino acids. So it's better to take ordinary protein in the form of meat, eggs, poultry, anything. Um, to build their muscles, not to experience any unknown tablets. Sometimes the tablets are unknown and the contents are unknown. So it's not healthy and it's not safe.
Unfortunately,
And if I can add a point
Doctor.
excellent point, Rajiv. Many of them, unfortunately, are, or not many, but some are taking extra anabolic hormones as well.
Yeah,
and
I said
they end up in our clinics, in the chronology clinics, with nice built muscles, but unfortunately with sexual dysfunction and gynecomastia.
Very true. And their
So,
testosterone levels are rather on the lower side. We have also
exactly.
seen that these young children or adolescents, those who are going to gyms, they are under the influence of their trainer there. They tend to consume a lot of protein supplementation along with anabolic steroid, and that actually increases the risk of hypertension, cardiovascular disease, and also developing
Yes.
maybe diabetes at a younger age.
Yes, this is Gamila
Yeah.
Nasr from Egypt, and I'm enjoying your discussion very much. And I think I agree with you that this protein supplementation is not very effective in many ways. And I think the key is the lifestyle medicine. We have to promote exercise. We have to be more energetic and avoid the sedentary life. So I think the natural way is the best way.
That is true. I think when you were talking about decoding the heart diabetes axis, I was thinking that is it gut liver adipose axis, which is also important when it comes to cardiometabolic risk, Dr. Gamila?
What, sir? What?
Gut,
What, sir?
gut,
What are you? I
gut
didn't.
liver adipose axis also contributing towards higher cardiovascular risk.
Yes, yes. I think there are, you know, I enjoyed the presentation very much because I think there are new caves, as Professor Institute have said. So I think the coming years will have a lot of new data about the mystery of the cardiometabolic syndrome.
And when it comes to cardiometabolic chaos, you find this new term. I really like this session. Is it reversible or only manageable?
Yes, I think it will be manageable. I
It is
think there are new data. I think the coming years will explore new medications,
Yeah.
which is for this. I think it's a mystery, and I think I said that it's a mystery. The cardiometabolic risk is a mystery because we have a lot of wealth pathways who we don't know about. There is a relation between, and I have attended the European Society of Cardiology meeting in Madrid. It's in Spain just a few days ago, and they all discussed how the systems work together. So I think it's a real problem that I think the gut will there will be a definite relationship between it and the I think it will be the mystery, the lipid profile, the blood pressure, the vascular function, the indirect cardiovascular risk. So I do think a lot of to be explored regarding the cardiometabolic syndrome.
Very good. Yeah. So, Mohammed, another one last question. Maybe you talk about obesity risk and that predisposes or drives rising prevalence of type 2 diabetes. And we have been talking of ectopic fat. It is an ectopic fat into liver, into muscle, into maybe in pancreas too. I remember one very good session by IDF President talking about that if you fast for 2 weeks, you can
Yes.
almost take away the pancreatic fat, which is the main culprit. So it is no more simply we early days we said it is an endocrinopathy. Today we say it is the liver which is the villain playing everything. And today we understand that even the pancreatic fat, as little as 2 gram extra or 3 gram extra fat in the pancreas can do huge amount of damage. So when it comes to reversal of obesity, you think that if we intervene early, do you advocate today that primarily it is the reversal of obesity which might reduce NCD? And should we intervene early, targeting sort of remission primarily by reduction of weight?
It's the two factors together, the reversal of obesity and increasing the physical activity. And as you saw from the data that I've shown you, and when I was chatting with Peter Schwartz about this as well, it's the two factors together. The physical activity, which is even more important than the reversal of obesity. We know that many people don't develop diabetes because they are physically active, even though they are obese. And talking about fasting, we need to think of fasting as a tool. We are used for religious fasting, where the person, once they fulfill the task, they overeat and they feast
after that. We feast after that.
And if we are to extrapolate from the skill and the expertise and tolerability of people who do religious fasting to when they eat, they take the benefit of the intermittent fasting and the healthy style of fasting, that would be extremely good. Peter do it for 2 weeks a year. I'm doing intermittent fasting for the last 2 to 3 years. And it does help a lot. And I think if people can invest in this, it would be very successful.
Very true. So before we sum it up, let me request Professor Inas. She has been the core committee convener for prevention of obesity, diabetes, metabolic syndrome in young adults and adolescents, in which is a IDF project. So let's have her final take on this entire session, which was primarily focused on obesity, aging related to sarcopenia, and obesity contributing towards cardiovascular risk, and the nexus decoding done by Professor Gamila. Dr. Inas, will you sum it up in 1 or 2 minutes?
Yes, and this gives me the chance to invite the audience to attend tomorrow's lecture about prevention of diabetes and the main IGF program, and also to invite the attendees and the professors and the colleagues to share in our prevention program. We started already. We had our sheet to start screening for adolescent obesity, and can be extended to adult obesity. So this gives me the chance to advertise about tomorrow's lectures. And today we had very important lectures about obesity, about the cardiovascular risk in obese patients and metabolic syndrome, and also about how to manage these important complications, about the metabolic surgery, and about sarcopenia and its relation to cardiovascular disease. So it was an important session today, and looking forwards to complete the program later on.
I think it has been an overwhelming session once it comes to cardiovascular risk, NCD, obesity linking with the cardiovascular risk or ectopic fat. In the beginning, we talked about adipocyte being the endocrine organ. In between, we concluded it is not only the adipocyte, but the muscle, which is also the culprit, and also increasing the cardiovascular risk in all young, adolescent, and elderly patients. So I'll now request Dr. Shalini to propose the vote of thanks and conclude the session.
Thank you very
Please
much.
unmute yourself. Yeah.
So thank you so much, everyone. I think this has been a very engaging symposium, and we've had such great discussions. It is a privilege to hear and learn from everyone here. My special thanks to all our faculties who took out time and joined us virtually from Egypt, Professor Iman, Professor Hisham, Dr. Amr, Gamila Madam, Dr. Inas, and Dr. Mohammed, who are with us in Delhi, and Dr. Antonio. Thank you so much. It was great discussions, a lot of knowledge exchange, and the concepts, the topics were so great today. I'm sure, it's really an eye-opening and mind-boggling thing, and we are just at the tip of the iceberg. There's so much to be uncovered. I think from the days when we thought diabetes was all about insulin deficiency and insulin resistance, we've moved on beyond the octet. We're talking about the gut, we're talking about the liver, we're talking about the adipose tissue. So I think it's very complex, and we're all there joining hands in this battle against diabetes and obesity. So all these CMEs, all these are intended exactly with the same purpose of knowledge sharing across the globe for the ultimate benefit, which is our patients, who need to be benefited with all the knowledge that we acquire with each other's experience. So it's a pleasure and a proud privilege to deliver this vote of thanks to all our esteemed faculties who've joined us, as well as all the attendees who've been logged on for the last almost 3 hours, listening to all these, asking engaging questions. Thank you so much, dear delegates. I hope this has been helpful. Of course, RX Events for all the support that you provided, the audiovisual support for the smooth running of this conference. Many thanks to AASD, Dr. Inas Shaltout, and the entire AASD team for partnering with us every year. It's always a pleasure, and we honor this partnership. With that, I welcome all of you to join us for the physical symposium tomorrow morning in New Delhi, starting at 9 a.m. at Le Meridian Hotel. I'm sure a lot of science, a lot of experts are here to share their knowledge. So I'll welcome all the delegates to join us tomorrow morning for a great engaging morning full of all the great academic exchanges. This was just the beginning, and I'm sure there's more to come. Thank you so much, and we look forward to a great association with AASD in the future also. Thank you so much for joining us today, all the dear faculties.
Thank you very much, and greetings from Cairo.
It was just a curtain raiser, and I'm sure, we assure
It's
you,
been
our
just amazing
organizing team,
science.
me, Dr. Shalini, Dr. Mohammed, and Professor Inas, all of us, we are part of organizing committee, and we have, I can assure you, we have crafted and drafted an excellent scientific feast. Everyone is going to benefit from them. So tomorrow, be ready. 9 a.m. we are starting right absolutely in the morning, .9.
Thank you so much. Have a great day. Thank you for joining.
Thank you.
Thank you.
Thank you so much.
All the best.
Thank you very much. Thank you. Thank you. Thank you.
Thank you,
Thank you very much.
Thank you.
Thank you. Thank you. Bye.
Bye.
Bye, ma'am. Thank you.
Bye.